Dr. Hanachen, are you here with us?
Hello, Bu Rizky. I'm here.
Hello, hello, Dr. Hannah. How are you today?
Yeah, I'm great. Thank you.
Thank you. Uh, what time is it? What time it currently in your place today?
It's 9:30 now in the morning.
In the morning? Oh, it's actually in the same time here. It's 9:30 now, so I can. I'm afraid actually assuming it's already morning there too. So, yeah, good morning, Dr. Hanachen. Um, Let me share her biography first. Uh, Panitia, boleh saya share screen? Panitia? Panitia, boleh saya dijadikan co-host? Saya bisa share screen? Pak Dona? Oke. Um, I will read her biography. Jadi, excuse me, Dr. Hanachen, I'm going to read your biography in Indonesia. Jadi, Dr. Hanachen ini adalah dosen senior. uh, oke. Jadi, Dr. Hanachen ini adalah dokter senior, ya, dosen senior di bidang kesehatan masyarakat di Departemen Ilmu Kesehatan dan saat ini sedang menjabat sebagai Ketua Pembelajaran dan Pengajaran Chair of Learning and Teaching di Fakultas Ilmu Humaniora dan Kesehatan Kartini University Malaysia. Beliau juga memiliki kredensial yang mengesankan ya. Jadi meraih gelar kedokteran medical degree pada tahun 2015, juga Master of Science in Public Health pada tahun 2021, dan juga keduanya itu meraih penghargaan uh, daftar dekan atau Dean List Awards. Kemudian juga beliau merupakan anggota kehormatan Distinguished Fellow dari Royal Society for Public Health dari United Kingdom. Juga dengan pengalaman lebih dari 7 tahun di bidang epidemiologi dan promosi kesehatan, Dr. Chen ini mendedikasikan dirinya untuk menjembatani riset dan praktik. Beliau berfokus pada pengintegrasian ilmu kedokteran, ilmu sosial, dan teknologi untuk mengembangkan intervensi kesehatan yang berkelanjutan. Beliau ini yang menarik telah menjangkau lebih dari 20 komunitas atau komunitas selama 4 tahun terakhir untuk mengimplementasikan program-program tersebut. Beliau, itu adalah biografi dari beliau. Dr. Hanachen, are you ready to deliver your presentation today?
Bu Rizky, should I share my screen now?
Yes, you can try first. If there is problem, we will back it up for you.
Thank you.
Okay, we can see the share screen. Okay, the screen is yours, Dr. Hanachen. Please.
Thank you, Bu Rizky. Assalamualaikum and good morning, everyone. It is an honor to be here and thank you once again for the invitation. So today I will start off with the topic prevention of teenage pregnancy in primary care, particularly at the primary care setting, especially in clinic kesehatan, clinics. So one of the reason why is it that I'm going to talk about teenage pregnancy prevention when it comes to maternal and childcare is that this is often an overlooked issue because we are very much focusing on pregnant women in marital age. As well as support and antenatal care to them. But those often overlooked concern is basically teenage pregnancy. So Why is it that we are here today? Is actually, of course, to ask ourselves how much do we know or understand about teenage pregnancy, right? So when you hear the term teenage pregnancy, what actually comes to your mind, and what kind of emotional or mental health challenges might teenage mothers experience, as well as a very important question today is what role do you think primary care clinics should play in preventing teenage pregnancy, whether you are practitioner, doctors or even nurses and also social workers. So what are your role in preventing teenage pregnancy? So I brought about this topic because of the data that we receive, up until 2023, and definitely right now in 2025 we have even a higher number. So actually data released by the Ministry of Health Malaysia, they recorded teenage pregnancy cases of 44,000 cases, out of which 17,000 cases were unmarried teenagers. So it is very important that we look at whether they are married or unmarried and what kind of support that they will get, during the teenage pregnancy period. And I also would like to share about Sarawak. So the place that I'm working at right now is actually near to Indonesia. So Sarawak basically is one of the state at the east in East Malaysia, the Borneo region, whereby it's also the state recorded one of the highest cases in 2023, that 9,000 over cases of teenage pregnancy, out of which 5,000 plus were unmarried teenagers. And when we talk about the high, number of cases of teenage pregnancy, it is basically very much due to the customary marriages, or what we call perkawinan adat, that actually allows this underage marriage. And also there isn't any amendments to raise the minimum legal marriage age for females to 18 years. So this is something very serious, and it is getting more and more serious, especially when the teenagers are nowadays exposed, to access to internet and social media, as well as the content that they are exposed to, like of course related to relationship and also sexual activity. So in Sarawak, just a quick one, as you can see, a few legal system on marriage. So we have the first one is definitely Islamic law, or the Sharia law, that stating that a female marital age, the legal age for marriage is 16, and for male is 18. But for the civil law, both are 18. However, of course, the law is really subjected to your ethnicity and also the religion. So if you are a Muslim, then of course it will fall under the Sharia law, that we must comply. However, for non-Muslim, they will be under the civil law. And in Sarawak, in Sabah, or any indigenous communities, even in the West Malaysia, they actually follow the native customary law, or we say adat. And one thing about this law is that there isn't a specific minimum age for marriage. So meaning to say that as long as the girl actually reach a puberty age that is capable of carrying a child, so they might actually just get married, and also of course teenage pregnancy will happen. So these are the things that we cannot really help from our side as a healthcare professional. But what we can do is actually our role in also to promote on how to prevent the teenage pregnancy, especially we have community that actually do not have a specific minimum age for marriage. So what are the roles that primary care have in preventing teenage pregnancy? So definitely very important is sexual health education. We actually have school health in our secondary school and also primary school as well. And definitely sexual health education is provided. However, it is also very important to look at what are the contents and why is it the number of cases, teenage pregnancy cases are actually increasing, right? And second one definitely is screening for risky behaviors and also mental health support and confidential contraceptive counseling and services, regular checkups, as well as, of course, counseling in terms of, family support and different kind of support, and also community support programs that we must actually engage the community with, not just the teenagers, but also their guardians and also the immediate adults that they will actually, contact with, for example, school teachers, principals, and so on. So in this particular sharing, I would like to share more on how the role of, primary care in sexual health educations and what are the things that we should actually include in the sexual health education. So basically, a quality sexual health education actually helps the student to develop skills and knowledge to help navigate healthy sexual development. So teenage is basically a transition, from childhood to adulthood, and that's why when it comes to even the physiology and of course cognitive wise and also the physical biological components, of the development is definitely very important that we need to take care of during this particular adolescence hood, and of course, this sexual health education is also very important for the students to gain knowledge, the teenagers to gain knowledge to avoid or reduce sexual behavior, because this will actually, eventually increase the risk for sexually transmitted infections, or we call STI, and then HIV, and of course, pregnancy. Yeah. So sexual health education definitely is also very important that we look into guiding them and sharing with them the impacts of teenage pregnancy. You can get pregnant, but you shouldn't. So teenage pregnancy actually occurs in girls aged between 10 to 19 years, some as early as 9 because of the capability, of having menses and also of course the egg production, that allow them to carry a baby. However, pregnancy at a young age is discouraged due to the negative impacts and of course the maturity of the body. Maybe some they are matured, but what about the cognitive thinking and also on the mental health side? So if you don't have enough support and you are a teenager, you are in transition to adulthood and get pregnant. So these are all the impacts that they need to know in terms of health risk, social impacts, as well as psychological impacts that they might, get, or the challenges that they might face. So, of course, health risk, I think everyone actually really, understand about this, the morbidity and mortality. But for the social impacts and also psychological impacts, these are something that we really need to touch on nowadays. There are many cases in Malaysia whereby, they actually left the baby in the petrol station or in the dustbin or even in the drain. So all these type of emotional challenges, and also even if they will keep the baby, so how is the social impact that they will receive, and also what about their education as well as job opportunity in the future, as well as to feed the child that the young mother actually delivered, especially those that are unmarried. So these are a lot of impacts that we are looking into on how why is it primary care has a very important role in teenage pregnancy prevention. Not just giving the maternal and child support or care and services, but also to prevent teenage pregnancy. So, what else that we need to know, right? So, other than the physical health, of course, mental health and social health, it comes also with substance abuse. Yeah, so alcohol, smoking, and of course, drugs, and eventually, of course, ruin a very young person's life. Yeah, and also unwanted outcome, maybe like a suicidal outcome, or something bad to the child even, that will actually happen in most of the in some of the cases. And then most of the mothers, like very young mothers, definitely will fall into mental health, different kind of mental health conditions. So of course, giving them the knowledge on the possible impacts, for of teenage pregnancy is very important, that they have the awareness not to involve in sexual behaviors or high risk behaviors. So we also definitely need to have the knowledge on what are the ways that we can teach them on pregnancy prevention. Definitely, pregnancy at a young age is discouraged, but if it is unavoidable, or sometimes there are domestic abuse or violence cases that we do not want, like some events, yeah, like for example, rape or maybe forced sexual intercourse, then these are some of the ways to prevent pregnancy. So definitely use of protection, yeah, and also those that are involved in the sexual activity at a very young age, to actually really avoid the sexual intercourse at all, and also to avoid having multiple partners. And also the use of contraception is very important. They need to know how long is the time frame, like let's say if in case of rape or maybe unwanted, like or maybe any kind of sexual activity that they involve in. So the emergency contraceptive pills that they can access, yeah, over the counter, they can go to the Klinik Kesehatan, and within the 72 hours to take the contraception. And of course, they need to know in case of it is unwanted event like rape, that they should actually not to wash anything, so that they will go to the clinic and the collection of evidence is there, so that they can file for legal protection, and also of course to report. Yeah. So these are some of things that we need to tell when we do the sexual health education. And of course, not just students should know, even the parents and immediate guardians should know, and not to pass this particular time frame, so that you will be able to get the emergency contraception, as well as of course to collect evidence, yeah, for legal protection. So, of course, it is also very important for them to have a clear, outline on what actually is rape or sexual assault. So, in Malaysia, we define rape as a sexual intercourse with a woman without her consent or against her will. So sex with a girl below 16 years of age, especially those in secondary school, regardless of whether it is like a, we call it suka-suka, yeah, whereby like she consents or not, this is considered a rape. So for women, they have a different saying, but for men, it is basically we use the word sexual assault. So definitely in Malaysia, rape is a gender-centric offense, and only women can be said to have been raped. But for sexual assault against a man as well, will also be an offense, and of course will get penalty, yeah, in law. So these are the things that they need to know, especially when it comes to teenagers, so that they don't simply engage in sexual activity, and of course to protect themselves against unwanted, incidents or, any kind of forceful situation, yeah, that they are in. And also, it's very important for them to know how to call for help. So these are the things that we actually share to the teenagers, as in like under what condition that you actually ask for help, and what are the rights that you have in terms of getting help, what kind of help that you will get, like safety or medical care, emotional support, and also legal protection. This is very important. And also definitely when they need to go to the clinics, the nearby clinics, and within how many hours, and what they shouldn't do, so that the collection of evidence can be there. And who and where. So we definitely have a flow chart in Malaysia. We have a flow chart on how, the steps on how they can call for help, and even the immediate guardian, yeah, or parents know what are the steps that they can take when something happened to their children, yeah. So and also definitely the hotlines, yeah, there are a lot of different hotlines that can provide support to teenage pregnancy, as well as mothers. So this is an example of one of the chart. We also provide, the flow chart for less than 16 years. This is considered as rape, right? And then 16 to 18 years, as well as those more than 18 years. So these are the things that we will actually share on how they can actually, approach the nearest clinic to get themselves, some help, and also, of course, to report and for further action. So other than pregnancy, it is also very important for us, as in like, especially in the primary care, as well as for community health intervention, to teach more on also not just pregnancy, but the possible health risk, which is sexually transmitted infections or STIs that they might get. So a lot of teenagers, especially the smaller ones, right? The younger children. Maybe they thought that, the infection can only be spread when, if there is maybe like a vaginal sex involved, yeah. But actually, there are different type of sex, and they should know about this when it comes to sexually transmitted infection, different road, and also transmission a pathway that can actually transmit infection, and even physical contact, kissing, as well as vertical transmission can also occur. So that if they know like the ways that they will get some kind of infection, that will actually, when we talk about infection, it's not just like you're getting sick, but also the possible complication that might affect them when they come to the marital age. Some of them cannot conceive anymore because of the complication of the infection, and some even is like if they will, caught HIV, then it is a very bad outcome as well for the teenagers in terms of also for their life. Yeah. So these are all the things that they should know when we talk about sexual health education. And most importantly, another thing other than telling them how the things how they will actually get the infection, the transmission, and whatnot. It is also very important to touch about the symptoms. One thing is that a lot of STI cases, as you can see, this is like an iceberg. Yeah, so in the ocean, the iceberg is only the tip that we can see. But whatever down there, these are all the under the water level. Yeah. So these are all the asymptomatic cases whereby there isn't any symptoms and they are not aware that they actually already caught that infection. So it is very important to tell them that if they will involve in any kind of sexual activity, and if there isn't even if there isn't any symptoms, they should do regular checkup and screening. So this is very important that they should have the awareness before things get late. Yeah. So some of the examples of the infection, of course, we share to the teenagers or the students. Definitely, the easier way, yeah, for them to know. Some common ones are like, for example, syphilis and also HIV. And also how to prevent. So this is a very simple step. A, B, C, D, E. Abstinence, meaning to say completely, totally stop. Yeah, avoid the sexual intercourse or activities. And then be loyal. Make sure that not a multiple partner thing. And also use protection. Yeah, condoms. And of course, we also have some drugs, for prevention and also education. So we also have community health intervention programs and also school sexual health education that they actually must know and listen to, and as well as to get the awareness, yeah, and the knowledge. So we also definitely, yeah, call for this talk test 3, because there are many times that of course STI, most of the cases asymptomatic, and you won't know that you actually get the STD. So it is very important to get tested, and of course if it is positive, and get the treatment to avoid further complications. So these are here is another chart for the STI prevention, and if there is any case of STI, it's also kind of like a flow chart that they know what to do. So the last thing that I would like to share today is actually to really to be an advocate, especially we are healthcare professionals, whether you are a nurse or community nurse, especially, or maybe primary care setting healthcare professionals, doctors. It is very important that in your clinic, especially, to actually share this type of flow chart, and also in a hospital setting, to allow them to to know that if somehow something like this happen, what should they do, how is the step. Okay. And we also have something called the one-stop crisis center. So if the teenager will go to the clinic, and then the family specialist will actually get in touch with the patient, and also of course collect evidence and do a thorough check, and refer the case to this we call it OSCC, right, in the hospital emergency department. Or if the teenager or maybe the immediate guardian or the parents can send them to the emergency department. So we have a OSCC, a one-stop center, whereby you can receive the medical care, as well as of course a police report, lodging, and for further action and legal protection, of course. So these are the things that we need to educate our community, so that there won't be any cases like unwanted babies, or maybe suicidal cases that we don't want to really want it to happen. And I would like to share as well, this is one of the program that we did, the Carnival Kesehatan Remaja Bahagian Miri in June this year, together with me, also Dr. Wotisa, for the psychology sharing for the teenage pregnancy prevention. So we did this program actually under the project to enhance the knowledge of teenage pregnancy prevention, and is the first district-wide adolescent health intervention that we collab with hosted with also the Pejabat Kesihatan Bahagian Miri of the Kementerian Kesihatan Malaysia. So don't be surprised with the result that we get from the data that we collected. So in this project, basically we did a one group pre-test, post-test quasi-experimental study that involved 146 adolescents aged 10 to 19 years old. Basically, the carnival, we have over thousands of participants, and we take some of them to get involved in the health intervention program. And the findings are quite surprising, because when we ask, are you in a relationship? And 10 to 19 years old, so 41.7%, so 42% say yes, and another 13% say that it is complicated. So you can see half of the teenagers, basically, that we asked somehow already involved in some kind of, relationship, whether you like it or not. And also, have you had sexual activity? This is very surprising, because when we look at the age 10 to 19, 8.3% yes, and 10% preferred not to say. So this is a very alarming percentage. And definitely, of course, we also get good result in terms of the increase of knowledge when we do sexual health education, as well as community health intervention program. So this is just one of the group that we engage with, some of the teenagers. And then here is our group, as well as the committee that actually involved in the program. So together with me, Dr. Wotisa, that she will do some sharing later for the psychological part. So for me is, I think we as a practitioner, field work is very important, and community engagement. It is not just doing research, but actually to translate the research into action, which is something that I would like to share, that we are not just collecting data, but to actually to benefit back to our community and to protect them, in order, to have better health for all, and of course, sustainable future. So one last slide, definitely protect our youth. Teenage pregnancy prevention is definitely a very important role that we should take, and is our responsibility. And let's make tomorrow better all together. And thank you. That's all from me.
Thank you, Dr. Hannah Chen. There is very insightful picture what currently teenage pregnancy happen in Malaysia. We in Indonesia too also still struggle with the teenage pregnancy. But in Indonesia, it's more like they are more like maybe because of the religion, we call it pernikahan siri. So it's not registered legally. There's a lot of marriage that are held like that, like the pernikahan siri. And once I also met like 12 years old married girl, but with a 40 years old man, and it still happened in Indonesia too. So it's really insightful what's happening in Malaysia. Thank you. So the presentation by Dr. Hannah Chen. We're really grateful. I open the Q&A section to the participant who wants to give question. You can type on the chat box, but if you want to give the question, you can also raise your hand, please. Untuk peserta yang akan bertanya, dipersilahkan bisa menggunakan bahasa Inggris atau bisa menggunakan bahasa. Nanti bisa saya bantu translate, tapi sepertinya Dr. Hana Chen juga sedikit paham dengan bahasa Indonesia mungkin. Dipersilahkan kepada peserta yang ingin bertanya mengenai presentasi yang telah disampaikan oleh Dr. Hana Chen. Saya persilahkan jika ada. Oke, while waiting, can I ask how the sexual health education uh, in Malaysia, is it implemented in the curriculum in school or not? Because in Indonesia, even if it already implemented in the curriculum, there are still some taboo that we face with the parents when we want to deliver the message of the sexual health education.
Thank you, Bu Rizky. It's a very good question. So actually, sexual health education definitely is already in the curriculum, and also we have, school health. So this is something very, important to share is that there is, but the teenagers seems not to be really, keen or maybe mature enough to actually to perceive the information. So it is very important as well, for them to actually have community engagement, to have another set of, healthcare professionals to deliver it once more. Because sometimes, actually even started, even since my time, last time, right? We do have sexual health education, especially in the high school settings. There are doctors that will come and share about teenage pregnancy prevention and whatnot. Yeah, but because of also of course the religion and also the cultural sensitivity, right? Especially, I believe it's the same as well in Indonesia, in Malaysia as well. Sometimes parents will got a shock that why is it that children need to know this? But if the children don't know this at all, it's a two-way thing as well. One is for protection, right? Another one is, of course, if they know it, maybe you might expose them. So this is the taboo that is going around. Like, it's better for you not to expose them to something like this. But we also look at right now, because of the increase of cases, and even if you don't expose them during the sexual health education, they can watch the thing online. So why don't provide them a proper education that they will know how that they can protect themselves and what are things that you should and shouldn't do. So of course, in terms of like curriculum and all this, it is there, but then it is also our responsibility when it comes to primary care. To do actually programs or community health intervention program, like once in a year, to actually again raise the awareness and also to provide more information, proper information in terms of sexual health education. Yeah, it is the same mentality like, for example, sometimes in school, yeah, at the school, you see teachers telling the student not to do this and that, and then suddenly they get another advice from another party outside the school, and then they might actually change their mind. So we need to not just rely on the school health, sexual health education by the community health doctors or maybe even the teachers, but also the health intervention program at community setting together with the teachers and the parents. So not just the teenagers. These are very important for us to see like a multiple different levels kind of intervention, yeah, in this.
Thank you very much, Dr. Hannah Chen. Okay, so continue. Maybe is there any question Baik, jika ada pertanyaan. Okay. Dr. Hanichen, because of the time, maybe we should have end here. So before we ending, allow me to present a certificate of appreciation to Dr. Hanichen. This is a certificate of appreciation for Dr. Hanichen for as a distinguished speaker for today's presentation. I would like to deliver a very thankful, also very grateful that you can join us today as speaker. Okay, before yes, sorry, but there is a question. Should we allow it? One more question for me, before we end it. Okay. For Karisma, for Kaba, dipersilakan. Karisma, for Kaba. Okay, please.
Yes. Thank you, Miss.
Hello, Charisma. Nice meeting
Hello,
you.
Hello, Dr. Hana. Good morning. First of all, thank you to Dr. Hana. Let me introduce myself. I am Karisma from Umkaba. So, my question, what are the long-term impact of the mental and physical burden of teenage marriage on quality of life? Thank you.
Yeah, so thank you very much because it's really a very wonderful, very important question. This is something that we really tell the teenagers during our health intervention program that day. Sometimes like yeah, the long-term impact. You see, it is not just about carrying the baby like during the pregnancy, but what about afterwards? Yeah, especially even those teenagers that married with they are married, but what if you married, what if that particular teenager was married to, a boy that is actually immature and don't have, have job insecurity issue, right? So employment not there, and then financial circumstance will be there. So the upbringing of their child will also be a problem. So of course, like long-term, impact on quality of life. When we talk, when we look into quality of life, right? There are different domains or aspect. If you look into the WHO, the World Health Organization quality of life, that on the physical health aspect, the mental health, the social relationship, and also the environment. So all these come together will definitely impact, of course, very much on the mother, yeah, the teenage mother. We look into, of course, their mental and also social impact. They also very difficult to get a job because of, sometimes might be dropped out from school. The education is not that good, and if really into the long-term impact, definitely is the child. So it is we should say that, how to say, the consequence is not just the two that actually involve in the sexual intercourse or the activity and then have the child, but not just the mother, of course, especially the mother, but also the child itself. And sometimes some even like if you have STI, right, and it will lead to complication, yeah, congenital abnormalities or whatnot, all are on the child. So if you really look into the quality of life, I believe that a different type of aspect that I have already clarified just now is really a very poor, quality of life outcome that you can see. And in Malaysia, and of course, we also see different type of mental health condition, and also social, yeah, cases. They throw the baby somewhere, and then maybe like a baby becomes orphans, right? So these are the unwanted thing that we don't want to see, like the quality of life of the different individuals, yeah, the mother and of course the father, right? So if the father is really very young one or immature, and definitely the child. So yeah, the quality of life definitely you can see like from different aspect, it should be very poor. And I believe that this is also a very good study, to check on like the different aspect, and also as an indicator on how we can actually improve their quality of life if things like this occur. Yeah. So thank you, Charisma, for your very good question.
Thank you, Dr. Hana.
Thank you,
It's clear.
Charisma. Thank you. Okay, thank you, Dr. Hannah Chen, for joining us today. So we wish you a great day today.
Sorry, Bu Rizky?
Yeah. Thank you for joining us today. We wish you a great day.
Oh, thank you. Thank you.
Thank you. Okay. We can proceed to the next speaker. For the next speaker, we have our second speaker. We have Dr. Faultisa Tartori. Dr. Faultisa Tartori, are you here with us?
Hi, Rizky. Good morning.
Do I pronounce your name correct?
Yes.
Yes.
Thank
Okay.
you. Yeah.
Hello, Dr. Faultisa.
I'm good. How are you? Thank you for inviting me to this conference.
Thank you for joining us today. Okay. I will read your curriculum vitae for in the beginning. Okay. I'm sorry. Excuse me. I'm going to deliver it in Indonesia. Dr. Tartori, Faultisa Tartori adalah Kepala Departemen Ilmu Kesehatan dan dosen dalam ilmu psikologi atau Psychological Science di Kartini University Malaysia. Beliau meraih PhD di bidang psikologi pendidikan dari IIUM on 2021 dari tahun 2021, di mana beliau dianugerahi sebagai mahasiswa terbaik dalam program dokter atau Best Student in Doctor of Philosophy. Dr. Faultisa merupakan dosen dan peneliti yang berpengalaman dengan publikasi di berbagai jurnal akademik internasional dan lokal yang melalui proses tinjauan sejarah atau peer review. Kemudian penelitiannya berfokus pada beragam topik termasuk kesehatan mental, kesejahteraan mental, psikologi pendidikan, kesulitan belajar, dan kesejahteraan populasi rentan. Beliau secara khusus tertarik pada bagaimana ilmu psikologi dapat mendukung remaja dan juga komunitas migran dan individu yang mengharapkan kerugian sosial atau pendidikan. Oke, Dr. Faultisa Tartori. Is it okay to just call you Dr. Faultisa?
No, you can call me Bautista. It's fine, Bautista. Okay.
Thank you. How are you today?
I'm doing good. How are you?
I'm good, thank you.
It's the same time. It's the same time with
it's the same.
Indonesia. 10:20.
Yeah.
Same time.
I'm ready to deliver the presentation.
Yeah, sure. So let me share the screen first.
Sure. Okay, Faultisa, the time is yours. Thank you.
Thank you, Rizky. Hi, everyone. It is pleasure to be here at the second conference on nursing and health sciences, Poltekkes. So my name is Dr. Faultisa Tartori, and I am the head of Department of Health Sciences and lecturer in Psychological Science at Kartini University, Malaysia. Today, I'm very happy to share an important topic that deserves more awareness and more understanding postpartum obsessive compulsive disorder, or postpartum OCD. This condition affects many new mothers, but often goes unnoticed or misunderstood. So in this presentation, I will walk you through the symptoms, the causes, and the treatment approaches with the hope of helping professionals better identify and support mothers who may be struggling. So without further ado, let's start. Now, becoming a parent is a major life transition. It's completely normal for mothers to feel a wide mix of emotions during pregnancy and after giving birth. The emotion they will feel is joy, they will feel fear, stress, overwhelm, sadness, and also anxiety. The hormonal changes can lead to lack of sleep and the new responsibilities that all mothers have to play. So it's a new role, it's a big transition for them. So if these emotions become so strong or persistent that they will interfere with daily life. For example, affecting sleep, caring for the baby, relationship with others, or in general functioning. So then it may become a sign of mental health issues, such as postpartum depression or postpartum anxiety. Now, postpartum depression, it's mainly about persistent sadness, low mood, or loss of interest in doing anything. So mothers, they may feel hopeless, they feel tired, they feel emotionally overwhelmed. Now, postpartum anxiety, it's mainly about the excessive worry they have, right? They have fear and they have these racing thoughts. So mothers feel constantly on the edge, they feel very tense and may experience physical symptoms like a heartbeat, like fast heartbeat. Now, sometimes emotions up and down are normal for the new mothers, but intense and long-lasting or disruptive symptoms should not be ignored and may be require a professional support. Okay, now depression affects women more often than men, especially during the age when women are most likely to have children. So the large international studies, such as Global Burden of Disease, shows that women have nearly double the rate of depression compared to a man. So at any given time, about 3.2% of women experience a unipolar depressive episode compared to 1.9% of men. Over the course of the year, 9.5% of the women will experience depression compared to 5.8% of men. And these higher rates are especially seen in women aged 18 to 44, which are the children bearing years. And this suggested that hormone changes during the pregnancy, childbirth, and the demands of caregiving contributes to the increased risk. So in other words, is that the women have more responsibilities than men. Okay. Now, having a common mental health problems are during and also after the pregnancy. Research shows that about 1 in 5 women will experience some form of mental health difficulty, either while they are pregnant or in the first year of after giving birth. So that means that these experiences are not rare. They affect a significant number of mothers. So one of the most common condition is postnatal or postpartum depression, which is simply feeling sad. It is a recognized mental health condition that affect mood, energy, burden with the child and daily function. So many mothers go through this, and it can happen even when they're during the pregnancy stage. And I mean, these emotions, are controllable, so it just naturally happen, to the mother. Now, postnatal depression, it's actually quite common, and more than 1 in every 10 women will experience it with the first year after giving birth. That means in any group of the new mothers, several are likely going through the symptoms, even if they don't show it on the outside. Now, it is also important to note that postnatal mental health difficulties can affect fathers too. Though the rates are lower compared with women, fathers they may struggle emotionally due to stress, also sleep deprived. They may suffer because of financial pressure. Now the financial, it increases because they need to provide for the baby, and it is a huge adjustment that comes with the new baby. Now, Princess Diana, she openly spoke about the emotional struggle she faced after childbirth. So, I mean, she spoke about this to break the stigma, and it reminds us that postnatal depression can affect anyone, regardless of the status they have, the background they have, or the personality they have, right? Postnatal depression can affect anyone. Now, why women are more vulnerable to depression, especially during the life stages? The key reason is the hormonal fluctuation, so shifts in the estrogen, and can influence the brain chemicals such as serotonin, which affect the mood, which affect the energy, and the emotional regulation. So women tend to face higher risk during the 3 major hormonal periods, such as the premenstrual stage. So some women experience significant mood symptoms before their period, known as PMS postpartum. After the childbirth, hormonal levels, drop dramatically. Combine, I mean, the symptoms they face is like stress, sleep deprived, and which, this emotion, it carries with depression if it is not given the right support. And then we have perimenopausal. As a woman approaches in menopause, we have hormone fluctuate, unpredictably, increase the likelihood of mood swings, right? Sometimes they feel all right, and then after a few minutes, they feel agitated and angry. So they have these depressive symptoms. Now, what are the postpartum OCD symptoms? Now, postpartum OCD is a specific form of anxiety that occurs after the childbirth, although it's less commonly talked about postpartum OCD, and it's quite of lack of research in this area. Now, postpartum OCD falls under the broader category of postpartum birth and or postpartum anxiety disorder, which usually appears in the weeks of months following the birth of the child. And then the characteristics that specify this diagnosis, it's intrusive thoughts. It is the unwanted thoughts paired with compulsive behaviors that parents, or especially the new mothers, use to try to reduce the anxiety. Now, the research suggests that 1 in 2 of the new parents experience postpartum OCD, meaning it's not rare, but it's often misunderstood because parents feel ashamed or they feel afraid to talk about it. So, I mean, they have kind of this extreme fear about the baby safety. Thoughts like if germs will harm my baby or if accidentally I hurt my child. So they have this compassion, such as, they have this compassion of excessively washing the hands, checking, avoiding certain object, or constantly seeking reassurance. So if they touch something new, so they will definitely go and wash their hand. Now, the symptoms of postpartum OCD. So here we have the key symptoms. So like I have already mentioned before, we have the most key characteristic here. It is the intrusive thoughts they have. So intrusive thoughts are unwanted mental images or idea that suddenly appears in the person's mind. In postpartum OCD, these thoughts are usually frightening and distressing, especially because they go against what the parent actually want to believe. So there are a few common patterns. Like they have these violent, intrusive thoughts. Mothers may suddenly imagine or harming or even sometimes killing the baby. And these are some of the intrusive thoughts they have. Even though they will never want to do this, right? They will never want to harm the baby, but just thoughts are in their mind. So these thoughts feel disturbing. They feel out of the character, and they feel they cannot control themselves. It is uncontrollable, right? They cannot control it. So these thoughts are the symptoms of anxiety, not a reflection of the real desire or the real intent that the mother wants to do, right? So they're nothing to do with the intention that the mom is having. And another symptoms is the avoidance or fear of the baby. Some parents start avoiding holding or being close to the baby because they are scared or they are afraid their intrusive thoughts might come true, right? Because all of these intrusive thoughts they have, like I said before, it's not their intent. They try to avoid the baby. So the avoidance is driven by fear, not lack of attachment. Now, again, symptoms of postpartum OCD. So another major symptoms of postpartum OCD, it is compulsively checking the baby. So mother experiencing, often they feel overwhelming, they need constantly to monitor the baby, which is far beyond what is typically for the new parents. So they may rapidly check whether the baby is breathing. They will check the baby temperature. They will check the baby's sleeping
karena dia udah
position.
bangun dari
They will
dari
check.
masa-masa SMA.
Pardon me, Dr. Faltisa. Could you unmute, please?
Okay, am I audible now?
Okay, thank you.
Yes.
All right. Okay, yeah. So like I said, so they will check any signs of health, right, of the baby. So they will keep touching the baby to make sure they are okay. So this goes beyond ordinarily parental caution. Right? For someone with postpartum OCD, the checking become excessive. It is time consuming, and also it is emotional exhausting. Right? Because they are just focusing on that. They have lots of fears. So this compulsion always checking, and it's time consuming, and definitely by the end of the day, they will feel exhausted. Now, the behavior usually comes from a deep fear, like I've already mentioned throughout this presentation. It's a deep fear that sometimes they feel like something terrible will happen. And also the fear that they might miss or a sign of danger. So they feel like a danger is on the way. As a result, this compulsive checking can definitely disrupt daily routines, increase, the stress, and it will disturb also their sleep, and which all this will worsen their anxiety, so they will not be able to function, especially the new mothers. Now, many new parents are naturally, cautious about the germs. But in postpartum OCD, this concern becomes intense. It becomes overwhelming. It's like a behavior should they repeat and check, right? So the cleaning is no longer about normal hygiene. It is driven by fear, right? It's driven by fear. So the parents with postpartum OCD may wash their hands always. They clean the household surfaces over and over again. They will sanitize the baby items far more than necessary, right? They will do it even though it is clean, everything is perfect, but they will keep doing. So they will avoid touching objects they believe are contaminated, And this action often happens when things look clean, because the fear is internal. Yeah, the parent images worst case scenario where germs could harm the baby. So that's the worst case scenario that the new mothers will face. For example, a mother might wash her hands every time she touches something new, rewash the baby bottles or the toys multiple times a day, clean the baby clothes immediately after they touch anything uncertain. So this compulsive cleaning, temporarily it reduces the anxiety, but it reinforces the OCD cycle, right? It increases the stress and making the daily life exhausting, because they are always driven by the fear. Now, the causes of postpartum OCD, the first thing is hormonal changes as one of the major causes of postpartum OCD. So during pregnancy and after the childbirth, a woman's body goes through dramatic hormonal shifts. They have the key hormones is the estrogen, which rise to the very high level during the pregnancy and then drop sharply after the delivery. So these hormones aren't only responsibility for supporting the pregnancy, they also play an important role in mood regulation, in emotion stability, stress response, how they respond to the stress, also the overall brain functioning. So when these hormones levels suddenly fluctuate, the brain chemicals involved in the mood anxiety, such as serotonin and dopamine, so it can also affect, so this can increase, the anxiety disorders, which include the postpartum OCD. Now, the core idea is that the biological changes during the pregnancy and after birth can make some women more sensitive to anxiety and intrusive thoughts. So these hormonal shifts do not cause the OCD on their own, but they can trigger symptoms in women who are already biologically or psychologically vulnerable to all of this. Now, another cause of postpartum OCD is the psychological stressors. So this is another major contribution to postpartum OCD. Pregnancy and childbirth are significant life transitioning, right? The life of the mom, but also to the father, will significantly change, even if they have the best situation, right? They have the support of the family, but the transition, it's a huge transition. So they come with, so they need lots of emotion support. They need to kind of adjust their lifestyle now. So the new mothers often deal with sleep deprivation, which affects the mood, which affects the concentration, and also the emotional regulation. They also might feel physical pain or discomfort from delivery of the baby to the recovery. So the pressure of caring for a newborn, especially with constant demand, a sudden increase in responsibility, which can feel overwhelming. So it's the change in identity of the person, is the change in routine, is the change in family dynamics. So all of these stressors can can increase the levels of anxiety. So when a mother is already tired, she's already stressed or emotionally stretched, her mind may become more sensitive to intrusive fears or intrusive worries that she has. So this one will increase the level of anxiety, which can contribute to the development or worsening of OCD symptoms. Now, another factor, it is social factors, is another important causes of postpartum OCD. So this one is beyond the hormones or the psychological stress. A mother's social environment plays a huge role in her mental health after the childbirth. So several social aspects can increase, her OCD level, especially postpartum OCD. First, it is lack of social support. So when a new mother does not receive the emotional, does not receive the physical support or practical help, especially during the early months of giving birth, her stress level will raise significantly, and she might feel alone, she might feel overwhelmed, and can make her intrusive thoughts more likely to occur. Another factor is poor relationship quality. Perhaps they have conflict with a partner, they have emotional distress, or lack of understanding can add pressure to the mother's new responsibility. So difficulties with the family can, increase the level of anxiety and can definitely contribute to development of OCD-like behaviors. Another factor, it is the emotional difficulties. Could be the financial stress, job insecurity, because now the mother has to be home to take care, but same goes also for the father. Worries about affording the baby, the important and essential things can, amplify a mother's fear and the sense of she don't feel stable in taking care of the baby. Another factor, it is the body image concerns. Pregnancy and childbirth bring major changes to a woman's body. For some mothers, these changes create, insecurity, which in turn, it affects their mood, it affects their self-esteem, and overall their emotional well-being, right? Because during the pregnancy period, they will have, these physical changes, and the mother will, face these insecurities. Now, the causes of postpartum OCD, we have traumatic birth experience can contribute to development of postpartum OCD. So childbirth is not only physical demanding, it can also be emotionally overwhelming. For some new mothers, the experience may involve fear, may involve the medical complications she have already faced during her childbirth, loss of control, or all of this can impact her emotional well-being. So when birth feels frightening, or when birth feels like a very tragic event, right? Mothers may experience this intense anxiety after the delivery. So they will constantly worry about their baby's safety. They will have these intrusive memories of the traumatic moments, and so the mom has difficulty in relaxing or feeling connected to the present moment, right? She is like worrying for something that nothing is happening, so she has difficulty to focus on the present moment. Or she might think about the past, which, it disturbs her, the present connection, the present moment. Now, the fear that the trauma might happen again in different forms. So these mothers then, they replay the distressing events in their minds. Sometimes they might replay rapidly. So this repeated mental replay can fuel anxiety and also can fuel the intrusive thoughts, all of which may trigger or may increase the level of postpartum OCD. Now, so what are some of the treatment of postpartum OCD? One of the most effective treatment for postpartum OCD, it is the cognitive behavior therapy, CBT. So CBT, it's a very well-known and well-established psychological treatment used for many mental health conditions, including OCD. So it focuses on how our thoughts, how our feelings, and behaviors influence each other. So it is a triangle: thoughts, feelings, and behavior. So they influence each other. Now, in postpartum OCD, mothers often struggles with intrusive and unwanted thoughts, and the compulsive behaviors they use to reduce their anxiety. They have these compulsive behaviors to do in order for them to feel okay. So their level of anxiety will reduce, but it is just temporary. Now, also, because the thing that I will do like is checking, cleaning, or avoiding the baby. So now CBT helps by teaching mothers to recognize intrusive thoughts as symptoms of anxiety. So it's not a real danger. So what the therapist will do, it will make the mothers recognize or be aware of these intrusive thoughts that are not real, and reducing the fear attached. Right? They want to break the cycle of fear attached to these thoughts, and so they will gradually helping them reduce, the compulsive behavior, so they no longer feel controlled by them. So it's like rebuilding the confidence in daily routine and parenting routine. So through structures, because there is a structure strategies, CBT allows new mothers to challenge, their unhelpful thinking patterns, and like I said before, break the cycle of anxiety and compassion, right? Break the cycle. Another treatment is meditation. I would say which is an effective treatment option for postpartum OCD. While therapy is the first line approach, many mothers benefit from combining therapy with meditation, especially when symptoms are severe or they are affecting their daily functioning. So the most commonly prescribed medication for postpartum OCD are the selective serotonin reuptake inhibitors, which increase the level of serotonin and the neurotransmitters that helps regulate the moods and emotional level. So it's like reducing the frequency of intrusive thoughts and lowering the anxiety levels. But of course, the medication should be given by a psychiatrist, so the mom cannot simply buy. So they need to be examined by any therapist or especially psychiatrist to prescribe the medication. But if you combine with CBT or ERP, it can be more beneficial in recovering faster. Okay, so here we have another treatment of self-care. So the role of self-care in managing the postpartum OCD, while therapy like CBT and ERP, it's beneficial, and also medication are, definitely important. But self-care practices important support by helping mothers, regulate the stress, calm their mind, and reduce the intrusive thoughts. So self-care can include the mindfulness and meditation. So these practices train the mind to stay in the present moment, because that's what the mother is struggling. She cannot focus on the present moment instead of getting lost in the fear or intrusive thoughts. One of the characteristics here, they can do like deep breathing, grounding exercise, reduces stress and help, break the cycle of anxiety. And of course, physical activity, even light movements like walking, stretching, yoga, or a gentle running releases, good hormones, which improves their moods and, help, calm their nervous system. So a very regular physical activity has been shown to reduce anxiety and compulsive behavior. We also have relaxation routines. This includes warm bath, listening to a calming music, or spending time outdoors. So they will definitely help reset the mind and the body when the symptoms feels overwhelming. So self-care is not meant to replace a treatment, but it significantly boosts the emotional resilience and improves the overall well-being, especially for new mothers experiencing postpartum OCD. So these practices, it will help them lower the stress, reduce the urgency of compassion's behavior, bring more balance to their daily life, and definitely it will improve their well-being. All right, so here we have other alternatives of treatment. So we have nutrition supplements, such as some mothers, they need to explore or take omega-3 fatty acid, vitamin D, or magnesium to help them regulate the mood and reduce the anxiety. While research is still growing, these supplements may benefit general mental health when used safely and under the professional guidance. They also can do herbal remedies, like they can take chamomile, lavender, something that can relax the mind. However, it is important for new mothers, especially breastfeeding mothers, to consult a healthcare provider before trying these remedies. Right? Everything must be advised by a medical officer. We also have another treatment, which is animal-assisted therapy. So interacting with trained therapy animals can reduce the stress, lower heart rate, and promote emotional comfort. So this kind of therapy offers, a gentle emotion support and has been shown to improve the mood and decrease the feelings of isolation.
Sorry, Dr. Kotisa. Just a gentle reminder of the time. We have less than 5 minutes, maybe. Thank you.
Okay, I'm almost done. Almost done. Okay, thank you. All right, so here, as I said, meditation is another form of treating the OCD. But here we have some therapy for postpartum OCD. So we have exposure response prevention, ERP, and cognitive restructuring, and also yoga. So these are some of the therapies that new mothers can join and do. Now, so these are some of the supplements that postpartum OCD mothers can take. We have omega-3, inositol, probiotics, and vitamin D. So thank you.
Thank you very much, Dr. Kotisa, for your presentation. It's actually a new thing to take aside of postpartum blues, and you just usually call it depression, but it's also a new category that is OCD that doesn't really known by broader aspects. So thank you very much. And then we open the Q&A segment to every participant who want to give question. You can also raise hand or type on the chat box. Untuk peserta yang ingin bertanya, dipersilahkan untuk raise hand atau menuliskan ke dalam kolom chat. Dipersilahkan. Okay, Dr. Foltisa, while waiting, you mentioned before that social factors and lack of support raise the chance of postpartum OCD. So what do you think role of midwives or nurses play to identify, like detection, and then for the during the routine checkups, maybe before the postpartum?
Thank you, Rizky, for the question. Yeah, it's important because, family members, they are not aware of this diagnosis. So who are the first people they can see when the mom are facing postpartum disorders? So there are so many, right? But I'm focusing today on OCD. So whenever they have checkup, they go and see the doctor and the nurses. So they need to have a conversation, daily conversation, especially with the moms, asking how they're doing. So while they're having this conversation, definitely, because an expert can see when the mom is feeling distress, or they can see the emotions, or they can see the behavior that the mom is having with the baby. Right? So they need to see the patterns that the mom is having, and they need also to kind of recognize these patterns, be aware of this, do some research, especially for nurses and also for doctors, but specifically for nurses because they are the first front row for dealing with the new mother. So then seeing what is the behavior pattern of the mom, how the mom is expressing, what are some of the fear that the mom is experiencing. Remember, OCD is something that it's the fear that makes the mom not being in peace, right? They have these intrusive thoughts, have all this unwanted behavior which they never want. So it's not in their character. So if the nurse sees all these patterns, so they can give the first hand. They can give the first hand because the father, which is the immediate family members, he is not able to see why his wife is reacting because he might also experience the same what the mom is experiencing. So yeah, nurses, they need to do some reading, some research, what are some of the symptoms to give the social support to the new mothers.
Yeah, thank you, Dr. Kotisa. Regretfully, because of the time, It's very excited. We're very thankful to have you here today. Before we end, maybe we can present a certificate of appreciation for Dr. Volti Sartori.
Thank you, Rizky.
Bapak bisa saya screen sertifikat. Okay, a certificate of appreciation from us to Dr. Volti Sartori as distinguished speaker today. We are very grateful that you can join us to this with us this morning, and maybe this is the end. Before we ending, maybe we can take a picture first as a documentation.
Sure. Thank you, Rizky, and to all organizers.
Thank you very much. Yes. Okay. Thank you. Okay, we take the picture. Okay, Voltisa, thank you for today. I hope you have a good day today.
Yeah, I had a great time. Thank you for invitation, and I
Thank you very much.
enjoy the rest of the conference. Thank you for invitation.
Thank you very
Have a
much.
good day, everybody. Thank you.
Bye. Okay, the next speaker. Today's speaker is Professor Chamini Jeba Priyaduraira. Is Professor Chamini here with us already?
Yes, ma'am. Yes, ma'am. The blood from okay.
Hello, hello, Professor.
Hello, ma'am.
How are you?
Fine, thank you.
Wow. It's like
a very
it's-
good wishes from India.
good wishes for you too.
Yeah,
How was the
thank
weather
you,
today?
Thank you, ma'am.
Yeah.
It's rainy here in my place, and we have a very chill weather also. It's nice meeting you all in this place with you all to share time. Can I start it, ma'am? Or
Yes, you can. You can
Yeah.
start to say.
yes, ma'am. You have taken a very good topic about. Will you be sharing my slide, ma'am?
Yes, sir. Please.
Yeah. Okay. It is nice that you have given a very good topic about maternal and child care, which is very, very important in our day-to-day life. And as a nurses, we have to give more importance to the maternal and child care. And today I'm going to talk about the artificial intelligence, how it is helping maternal care. All of us are not very much techno savvy, but still all of us will be hearing the term artificial intelligence. So this artificial intelligence
Excuse me,
yes.
Professor. Have
Yes.
you screen?
Hello, you are not very audible, ma'am.
No, it's not visible yet. Okay.
Yes, ma'am.
Yes.
Can I continue?
Pardon me, Professor.
Can I continue, ma'am?
Pardon me, Professor.
Uh,
Can you show your
Can
slide?
you share screen?
Slide is there, ma'am. I have sent the slides,
Oh, wait a minute. We are going to share screen.
or I have to share the slide.
Committee, do you reserve the?
In that case, can you give me some more time on 5 minutes?
Yes, sure.
Yeah, by the time I'll be ready, ma'am. Hmm. One by one. Start from. Ma'am, can you able to see? Hello?
Yes, we able to see it. We see it, but it's
It's in PDF form, ma'am. That's why I could send it one by one. Click it one by one.
okay.
Is it visible, ma'am, now?
Yes, we can see it.
Okay, ma'am. Okay, ma'am. So now we are going to talk about artificial intelligence in maternal care. Maternal care. Okay. With child and maternal. Next slide. Child and maternal care health are key components of every country's growth. In early 1990s, world leaders approved 8 Millennium Developmental Goals, that is MDGs, including improving maternal health and reducing infant mortality by 2015. Between 1990 and 2050, the program has resulted a decreased number of deaths in women and children under the age of 5, which is reduced to half since 1990, and MMR is decreased to 45% globally. But in 2015, since we didn't achieve it, WHO proposed sustainable developmental goals to set up 17 objectives to be accomplished by 2030. The third SDG, that is Sustainable Development Goals, aims to ensure healthy lifestyle for all to people on the planet, including a reduction in maternal mortality to less than 70 deaths per 1 lakh live births and neonatal MR to less than 12 deaths per 1,000 live births. Maternal health is concerned with the health of women throughout gestation, childbirth, and postpartum period. So, now let us see about artificial intelligence. So artificial intelligence will be helping us in doing our research work, and also it helps in the care of people in the remote area. Healthcare workers, those who are working in the remote area, are more beneficial with this artificial intelligence. So what is artificial intelligence? AI is the ability of the machine to perform tasks that typically require human intelligence, such as learning, problem solving, and decision making. Artificial intelligence is revolutionizing maternal health through application in early detection. What are the principles of AI? Uh, Human oversight, technical robustness and safety, privacy and data governance, transparency and explainability, fairness and non-discrimination, societal and environmental well-being, and accountability. What are the five pillars of AI? One is transparency, second one is fairness, privacy, accountability, and sustainability. Then what are the five advantages of AI? That's not very clear, ma'am. That five advantages are: it will reduce human error, its ability to perform risky or repetitive jobs, faster and more informed decision making, increased efficiency and productivity, and it is 24/7 availability. What are the key applications of AI in maternal health? Predictive analytic and improved accessibility. All of us nurses are working towards prevention of complication in maternal care. So the prevention include our data collection, our care to the mother, all these things. There are three basic principles of AI in care of maternal care. Those include improving diagnostic accuracy and early risk detection, enhancing personalized and proactive care, and enhance accessibility and resource optimization. Now let us see what are the AI tools which are helping us in the healthcare sector. AI tools, healthcare are used in wide range of application, including medical diagnosis through image analysis, drug recovery and development, clinical decision support, and robotic surgery. All of us are very much aware in many places nurses are replaced by robotics. So robotic is actually done by this AI tool, and also whatever the CT scan or other thing done for the mother are being explained by the AI tools. Now doctors and hospitals are more dependent with the AI tools rather than the manual method of taking care of human being. They also improve administrative efficiency by automating tasks and also managing data and processing claims. It also enhances patient experience through chatbot and remote monitoring. And what are the most prevalent complications in maternal care? First one is high blood pressure, which can lead to preeclampsia and eclampsia. Second one is gestational diabetes, which can cause delivery complication. Then infections acquired during pregnancy, preterm deliveries, and miscarriage and loss of fetus. That is abortion, which is faced by the women. How AI improves women's health? It helps it through early detection by scanning methods and to detect any abnormalities in the fetal development. Then personalized treatment plan. Once we come across the After deducting anything, we talk with the mother about the treatment plan and more efficient healthcare processes, then bridging expertise gap along with the doctors or with a group of healthcare members to take care of the mother, accessibilities and empowerment, and reduce bias on the trials. And what is the role of AI in maternal health? The AI, that is usually the machines which is helping us in monitoring maternal health. So that, for example, we use Doppler machine to check the fetal heart rate. Earlier, we used to use manually fetoscope or PNAT scope, but that has been replaced. Even our own nursing students using all these present technology development instruments. Second one is predicting risk of preterm deliveries and miscarriages. It helps us to diagnose exactly the place of placenta, preeclampsia and everything. Then predicting gestational diabetes and miscarriages, predicting DVT complications in females, predicting suffering with congenital cardiac diseases, predicting gestational anemia, predicting postpartum depression, and predicting anxieties. By calculating the calculation, it is usually helping us into this. Then what are the focus areas on role of AI in complicating maternal health? That is during gestation and also during postpartum period. During gestation, maternal health monitoring, preterm deliveries, gestational diabetes, congenital cardiac disease, gestational anemia, and improper growth. And how we can diagnose this by early detection by using AI. Medical imaging analysis, predictive analysis, symptom analysis, personalized medicine, continuous monitoring, and somatic detection. Then how artificial intelligence reduces maternal mortality. By early detection, identification, and prediction, enhanced diagnosis, clinical decision, optimized resource allocation, improved patient engagement, and education. All these points are very self-explanatory. That's why I'm not explaining it in very detailing. So to prevent any complication in pregnancy, early risk identification is very much necessary. That's what they do, early scanning and enhanced diagnostic method. Every month they come for the checkup where we do all the diagnosis and clinical decision done by the doctor along with the nurses and also with the support system of the mother. Then whatever resources are available, we have to allocate. In India, if we see, the mothers are paid 3 times to take care of the nutritional care. That is like they pay every trimester some amount, and every day we have in the primary health center, if the mother comes, we give them a nutritional ball so that the anemia can be prevented. Any other complication, very good nutrition will be supplemented to the mother. And also the nurses give education to the mothers whenever they come. And if you visit any of our primary health center or urban health center, it is mostly dedicated to the maternal care. You can see many charts and charts are prepared for the easy understanding for the mother. next we'll see what is the role of AI in the healthcare. I have given you five points. Sorry. Let us go. Let us see the neonatal healthcare. Not only the maternal care, and also AI is helping us in the one minute, sorry, in the neonatal health complication by during the gestation, stillbirth can be prevented, and during postpartum period, we can assess the pain assessment, infection, and improper growth, which may lead to sepsis and jaundice. Those things can be prevented into it. Now, since we are using machines, we have to see the ethical consideration. So it protects autonomy, and it promotes human well-being and safety, human safety and public interest. It ensures the transparency, explainability, and intelligibility, and it fosters responsibility and accountability, and it ensures inclusiveness and equitability. It promotes AI that is responsive and sustainable. And while we are considering any research program, we have to use 30% rule in AI. When various research implementation studies, a figure of approximately 30% have been associated with a positive impact of AI in maternal health care. It can reduce complication, it can enhance decision making, it helps in specify risk factors. The 30% rule in AI in maternal care refers to the significant reduction in adverse outcomes demonstrated in some studies in AI is used effectively for prediction and resource allocation and decision support. Next, I wanted to share a small thing, how this AI is used by even remotely accessible population. I got this information through Google search. It says Mariam Mustafa, a professor in Lahore University, she has developed an app called Awaz-e-Sehat, that is meaning voice of health in Urdu. It can be used, downloaded, and it can be used in the smartphone, and it has many structured questions in the local languages to identify the problem faced by the mother. For example, if a mother is having preeclampsia, she may not be knowing the disease condition, but she knows the signs and symptoms. If she sees pedal edema in the leg, she can go through this app, and through the questionnaire, she can find out what she is suffering from. It can help her to go to the doctor, visit a doctor, and in care of her. And this can used in the research setting also, and it can be used by the nurses also who are posted in the remote area if no doctors are accessible. So we can check into that, and this is one of a very good app. We can use it, but we can try even in our own countries. Next is the challenges and considerations. What are the challenges? Are ethical concern, data limitation, and implementation. Next, we'll see what are the barriers. Any machines can have a positive also and negative also. Let us see what are the barriers in that. So in economic and social barriers, comorbidities and abnormalities, and technical barriers, since these AI missions are very costly ones, only the governments will be able to provide us. Non-availability of large-scale database, evaluation and validation, and trustworthiness and explanatory of the models, and concerns about privacy and acceptance of the AI models. Coming to the conclusion, the use of AI, artificial intelligence, machines, and tools. So hope you understood what it is like. It can also improve the understanding of intra-group differences among conditions that primarily affect women, which have frequently been dismissed or misdiagnosed, such as uterine fibroids, polycystic ovary syndrome, and menopausal syndrome. That AI machines are very much in use, not to confuse with the very big machines, even the smallest machines, like even our Doppler machines which can be used to check the fetal heart rate, is one of the AI missions. As technology is evolving the world, we nurses also have to become very much techno savvy, and also with the use of all these machines, we can prevent maternal and neonatal mortality. WHO, which is working towards it, also is helping every country in improvising the to reduce the maternal and infant mortality. The last question which I am giving you is, will midwives can be replaced by artificial intelligence? It definitely will not. It can help in our life, but nurses and midwives will not be replaced by the AI. This artificial intelligence, now we have to include in our curriculum, in nursing curriculum also, so that nursing students, future generation nurses, will be eligible to understand the machines and what it is. Being next to the mother alone will not help us in deduct test to confirm it. This also will be, machines also will be helping us to conclude it. Thank you, ma'am, for giving me this opportunity and helping me to present myself with the artificial intelligence, how it is helping us with our maternal care. Thank you.
Thank you very much, Professor Chakri. That's a very insightful of the presentation. Because here in Indonesia, not really developing and integrating the AI into the clinical setting. Of course, it's a new thing for us to include in the clinical practice. So, to the participant, maybe if you want to give question to Prof. Charmini, we are pleased. You can raise your hand or write it on the chat box. Jika ditanya, dipersilahkan kepada Prof. Charmini. Okay, first, maybe before while waiting for the question from the participant, can I ask, because it's not implemented yet in Indonesia about the generated AI system in the clinical practice, how far we can critically trust and interpret the this AI when we are facing the maternal complication like preeclampsia or sepsis?
Madam, AI is mainly to check the fetal well-being and maternal well-being. Definitely sepsis and other things cannot be checked with a machine. Only by biochemical parameters alone we can check it with that. But we can check the complication in the mother, such as the placental abruption and other things. And also in the neonatal, IUGR, all these can be deducted with that.
Right. Thank you. Is there any case that you have faced before that you can share to us, when you are using this AI system in practice?
I'm not getting you, ma'am.
Can you hear me, Professor? Hello?
Hello?
Professor?
Yeah, yes.
Yeah. I'm just asking if you can share your experience while using this AI system during clinical practice, maybe.
In clinical practice, definitely AI will be helping, ma'am. See, when sometime nursing students, when you are posted, since I'm in academics, I'm telling you, student may not be able to differentiate the uterine pulse sound with the fetal heart rate. Am I correct? So in those situations, if we use Doppler machine to check the fetal heart rate, that will help the student to know when the mother is in the pain in the process of first stage and second stage. Definitely it will help the student to understand what it is and how it is. Definitely AI will be helping them, and I'm sure in future many more machines might come up with for the maternal care, and especially it will be useful in the areas, in the remote areas like hilly areas, in the villages where not much healthcare is not available. It will be definitely helping the village health nurses who visit the mother in the home or in the house during the house visit. It will definitely will be helping them, ma'am.
Thank you very much. Fortunately, because of the time, it's very limited. Have to say goodbye here. But before ending here, I would like to present a certificate for our
Thank you.
for today presentation and insight you are sharing with us.
Okay. Thank you, ma'am. Thank you for the certificate.
Thank you very much. We wish you have a very nice day. But before that, maybe we can take some photo for this screenshot, maybe for this documentation.
Okay, ma'am. Sure, ma'am. Sure. Sure.
Okay. 1, 2, 3. Okay. Okay, that's it. Professor Charlie, thank you again.
Thank you, ma'am. Thank you, ma'am. Have a good day. Thank you. Okay, ma'am. Thank you.
And that's ending our third speaker. We are stepping into the fourth speaker. This would be Prof. Saima. Oh, okay. Big professor is not here yet. So welcome our esteemed speaker, Ibu Nur Sriana. Halo Ibu.
Halo Mbak Rizky. Apakah suara saya terdengar?
Sangat jelas Ibu. Assalamualaikum.
Waalaikumsalam Bu Rizky. Salam kenal. Alhamdulillah baik.
Baik, izin Ibu saya share screen dulu untuk di Ibu.
Iya baik.
Baik, beliau nama lengkap Ibu Nur Sriana, akrab dipanggil dengan Ibu Nunu. Beliau memiliki ketertarikan terhadap ilmu keperawatan anak dan telah bergabung menjadi pengurus Ikatan Perawat Anak Indonesia atau IPANI di Sulawesi Selatan. Dan sudah bergabung menjadi tim Satgas COVID-19 PPNI Kota Makassar sebelumnya. Pendidikan terakhir beliau itu Magister of Nursing University Hasanuddin Makassar. Dan kemudian beliau juga memiliki banyak penelitian yang sudah terpublikasi baik jurnal nasional, Sinta, ataupun terindeks Scopus. Pengalaman organisasi beliau tadi sudah disebutkan, beliau anggota dari PPNI, kemudian juga IPANI dan IKA alumni PSMIK Universitas Hasanuddin Makassar. Beliau memiliki pelatihan-pelatihan yang yang pernah diikuti seperti pediatric basic life support dan lainnya, dan juga memiliki keterlibatan di daerah bencana seperti penanganan trauma healing pada anak di daerah Sulawesi Barat, di Masamba dan di Mamuju. Nah, ini adalah kontak beliau, email, kemudian nomor HP dan Instagram juga Facebook nanti bisa di-add sama teman-teman ya. Oke,
Baik,
mungkin Ibu untuk singkat waktu itu saya persilakan untuk mempresentasikan bisa dicoba share screen dulu Ibu.
ya baik Bu. Terima kasih Bu Rizky atas kesempatannya. Izin share screen. Izin Bu, apakah sudah terlihat?
Kalau di saya belum ini Bu. Sepertinya. Oh, sudah Bu. Ya,
Baik.
dipersilakan Ibu.
Tunggu saya slideshow. Oke, baik. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Dan selamat siang. Kalau sudah di Makassar sudah menjelang siang hari ini. Sebelum saya mulai share sedikit informasi terkait inovasi program kesehatan ibu dan anak di era globalisasi. Pertama-tama yang terhormat Bapak Direktur dari Poltekkes, Bapak Direktur dari Poltekkes Kemenkes Mamuju, terima kasih atas kesempatannya, dan Bapak Direktur dari Global Health Science beserta teman-teman dari presenter dan panitia dari Poltekkes Kemenkes Mamuju, dan Ibu Dr. Livana juga yang sudah mengundang saya untuk beberapa kali ikut di kegiatan ICNHS ini sampai sudah ke-20 kali insya Allah ya. Mudah-mudahan bisa bergabung di event-event berikutnya bersama Ibu Rizky. Baik, untuk mempersingkat waktu saya sedikit share terkait inovasi program kesehatan ibu dan anak di era globalisasi. Kenapa saya tertarik untuk membahas sedikit terkait program kesehatan di era globalisasi atau digital untuk saat ini, karena melihat banyak sekali kasus-kasus ibu yang meninggal pada saat ingin diberikan pertolongan pertama proses persalinan, atau ibu hamil dan tidak terkontrol proses pemeriksaannya, dan beberapa kasus-kasus yang mestinya kita cepat tanggap untuk memberikan pertolongan kepada ibu yang dan anak yang memerlukan pertolongan secara cepat. Baik, untuk latar belakang mengapa digitalisasi kesehatan ibu dan anak ini penting, melihat beban global angka kematian ibu dan anak masih menjadi prioritas global ya, terutama di beberapa daerah pelosok seperti yang kasus baru-baru ini, daerah Papua kalau saya tidak salah ada istilahnya kejadiannya sangat butuh perhatian dari pihak baik itu yang terkait dari rumah sakit, puskesmas ataupun pemerintah setempat untuk proses rujukan yang terjadi baru-baru ini, yang katanya akan dirujuk sampai melewati 4 tempat rumah sakit yang sampai meninggal pasiennya di proses rujukan akhir seperti itu. Untuk revolusi digital, penetrasi smartphone dan internet yang tinggi membuka peluang baru untuk transformasi layanan kesehatan. Efisiensinya, digitalisasi dapat menyederhanakan proses, memangkas biaya dan meningkatkan jangkauan. Dari mungkin kalau misalnya efisiensi untuk daerah pelosok ya mungkin perlu perhatian khusus juga, karena sekarang untuk akses di mana saja itu sudah bisa, cuman sosialisasinya yang perlu mungkin dipermantap atau diperdalam dari pihak pemerintah, sehingga semua masyarakat baik itu di pelosok ataupun di daerah yang masih mudah untuk proses seperti rujukan dan lainnya, itu bisa menurunkan tingkat kematian dari ibu dan anak. Kemudian tantangan akses itu ada ketimpangan geografis, daerah wilayah masing-masing di pelosok, kemudian biaya dan tenaga kesehatan yang ditugaskan di daerah tersebut. Apa itu health and e-health untuk KIA? Di sini saya melihat sedikit kutipan dari beberapa penelitian itu mobile health. Penggunaan perangkat mobile seperti ponsel, tablet, dan aplikasi untuk mendukung praktik kedokteran dan kesehatan masyarakat. Misalnya SMS reminder untuk mengingatkan bahwa Ibu untuk jadwal pemeriksaannya untuk hari pekan depan misalnya sudah bisa datang ke wilayah tempat-tempat pemeriksaan kesehatan seperti puskesmas ataupun rumah sakit. Adapun aplikasi kehamilan sekarang sudah bisa diakses lewat Play Store. Tinggal kita mensosialisasikan kira-kira aplikasi apa yang terbaik untuk diberikan pada ibu hamil yang mudah dipahami, karena sekarang banyak juga aplikasi terkait kesehatan ibu hamil dan kesehatan anak yang agak susah dipahami oleh masyarakat setempat, apalagi yang mungkin tingkat pendidikannya yang masih kurang menurut penelitian. Kemudian konsultasi via WhatsApp, bahkan beberapa sekarang itu di daerah Makassar, walaupun istilahnya daerah Sulawesi Selatan masih banyak juga yang masih kurang mampu untuk mengakses WA, tetapi biasanya itu untuk istilahnya yang penanggung jawab daerah puskesmas itu biasanya mengajarkan atau mensosialisasikan kepada ibu hamil untuk mendownload misalnya aplikasi ini atau misalnya memasukkan langsung ke dalam grup sebagai penanggung jawab dari ibu hamil atau kesehatan anak tersebut. Kemudian e-health, electronic health, penggunaan teknologi informasi dan komunikasi secara luas untuk kesehatan. Misalnya rekam medis yang di rumah sakit atau sistem informasi kesehatan dari ibu dan anak dan telekonsultasi. Baik, untuk kerangka konsep di inovasi digital KIA, atau kesehatan ibu dan anak, di sini input dari data itu adalah kebijakan dari masing-masing rumah sakit ataupun puskesmas, teknologi, dan SDM. Sumber daya ini yang sangat penting untuk mengetahui juga tentang digitalisasi untuk program-program yang akan disosialisasikan kepada masyarakat. Kemudian prosesnya aplikasi, platform, atau SMS yang berupa informasi kesehatan yang penting bagi ibu hamil dan anak-anak. Fokus pada siklus hidup, kehamilan, persalinan, nifas, bayi baru lahir, dan balita. Melibatkan berbagai pemangku kepentingan seperti ibu, keluarga, dan tenaga kesehatan dan pemerintah setempat. Inovasi digital untuk KIA, di sini aplikasi kehamilan dan pemantauan dini sudah banyak bisa diakses ya di Play Store masing-masing, baik itu di di handphone ataupun di tablet masing-masing. Ibu yang akan diberikan sosialisasi terkait kesehatan untuk memantau sejak dini mulai proses kehamilan sampai persalinan. Pemantauan perkembangan janinnya bagaimana dan perubahan tubuh ibu, kemudian kalkulator usia kehamilan dan jadwal pemeriksaan atau antenatal care-nya, kemudian informasi nutrisi, kira-kira makanan apa yang cocok untuk ibu hamil yang memang ada riwayat misalnya hipertensi dan segala macam, ada riwayat penyakit yang bisa mengganggu nanti di akhir untuk proses persalinan. Olahraga dan tanda bahaya. Konsultasi langsung dengan bidannya atau dokternya ataupun penanggung jawab persalinan. Kemudian manfaatnya bisa meningkatkan pengetahuan dan kepatuhan antenatal care, dan di samping juga kalau misalnya kita secara digital kita bisa memantau lewat langsung dan bisa memberikan informasi kalau misalnya ibunya terkendala untuk datang langsung ke puskesmas atau rumah sakit ya, jadi bisa kita pantau lewat HP. Kemudian inovasi digital untuk KIA bisa via SMS ataupun telepon, bahkan sekarang tidak ke SMS lagi ya, bahkan ke WA ataupun beberapa aplikasi yang bisa kita pantau bahwa oh ternyata pasien saya untuk ANC ini sudah waktunya kunjungan di daerah-daerah rumah sakit atau puskesmas. Fungsinya untuk mengirimkan pesan atau panggilan otomatis untuk mengingatkan jadwalnya, jadwal kunjungan yang seharusnya biasanya kalau ANC itu kunjungannya berapa kali, biasanya kan mungkin ibunya sibuk di sawahnya atau di kebunnya sampai lupa untuk memeriksakan kehamilan. Sehingga pada akhirnya biasanya ibunya pada saat proses persalinan ada penghambat untuk proses lahiran normal seperti ligitan tali pusat dan lainnya. Atau kelainan letak. Kemudian imunisasi anak ini juga penting untuk kelengkapan imunisasi pada anak. Karena kenapa? Kalau misalnya untuk mencegah ya, karena imunisasi ini tidak mengobati tetapi mencegah terjadinya beberapa penyakit-penyakit ya, penyakit-penyakit yang memang notabene dicegah oleh beberapa tahap imunisasi, terutama 9 imunisasi yang memang harus diberikan kepada anak. Kemudian minum tablet tambah darah untuk biasanya anak-anak remaja. Ini sekarang program di Sulawesi Selatan itu kami bersama teman-teman di Puskesmas itu biasanya ada pembagian tablet FT untuk di sekolah-sekolah. Untuk SMA biasanya untuk anak remaja putri. Kenapa sasarannya ke anak remaja putri? Karena nanti anak-anak tersebut adalah generasi penerus untuk nanti kemudian akan menjadi seorang ibu yang akan melahirkan misalnya. Seperti. Kemudian manfaatnya sangat efektif di daerah dengan jaringan internet terbatas meningkatkan cakupan layanan. Inovasi digital untuk KIA bisa jadi telemedicine atau telekonsultasi. Fungsinya konsultasi jarak jauh dengan tenaga kesehatan via video call maksudnya, telepon ataupun chat pakai WhatsApp. Kemudian manfaatnya mengatasi hambatan jarak dan transportasi, triase awal untuk menentukan perlu tidaknya rujukan, konsultasi laktasi dan perawatan bayi. Inovasi digital untuk kesehatan ibu dan anak di sini, wearable device untuk ibu hamil. Di sini juga semacam aplikasi untuk memantau tanda-tanda vital ibu dan janin secara real time lewat aplikasi. Contohnya monitor detak janinnya, kemudian kontraksi rahimnya berapa, kemudian tekanan darahnya. Manfaat deteksi dini komplikasi seperti preeklamsia atau gawat janin. Bahkan saya baru-baru melihat ada semacam aplikasi untuk mendeteksi, jadi kita tidak usah pakai test pack lagi untuk beli test pack lagi di apotek ya, tetapi ada aplikasi yang kalau kita tempelkan di nadi kita di pergelangan tangan itu sudah bisa terdeteksi bahwa oh si A ini hamil, si B ini hamil. Jadi pada saat kita mendeteksi tangan, kita letakkan tangan seperti ini di HP, kemudian akan terdeteksi, akan muncul garis 1 atau garis 2. Cuman saya lupa apa nama program aplikasinya. Ya. Untuk inovasi digital kesehatan ibu dan anak, bisa kita juga menggunakan platform informasi dan edukasi terpercaya, situs web atau portal yang menyediakan informasi. Kalau misalnya yang seperti ini biasanya agak susah diakses oleh seorang ibu, tetapi kalau misalnya kita langsung memberikan aplikasi dan mengajarkannya, mensosialisasikannya, itu biasanya agak mudah. Kemudian manfaatnya melawan informasi dari sumber tidak terpercaya atau memberdayakan orang tua dengan pengetahuan yang akurat. Inovasi digital untuk kesehatan ibu dan anak, kita juga bisa memantau pemantauan digital dalam 1000 hari pertama kehidupan atau 1000 HPK. Ini merupakan periode kritis untuk mencegah stunting, melihat kondisi stunting kita bukannya turun kelas tetapi naik kelas ya, karena mungkin kurangnya pemantauan dari status gizi si anak yang memang sudah terdeteksi stunting dan optimalkan tumbuh kembang. Masa emas ini dari konsepsi hingga usia 2 tahun, dampak jangka panjang menentukan kesehatan, kecerdasan pada anak, dan produktivitas. Peran digital memastikan intervensi tepat waktu melalui pemantauan berkelanjutan. Inovasi digital untuk kesehatan ibu dan anak, di sini pada saat fase kehamilan 270 hari pertama itu pemantauan gizi ibu, trek berat badan, lingkar lengan atas dan asupan gizi yang penting pada ibu hamil. Karena biasanya kalau misalnya terjadi emesis atau hiperemesis, nah itu yang biasanya membuat si ibu untuk susah mengkonsumsi makanan-makanan yang bergizi. Kemudian suplementasi pengingat konsumsi tablet tambah darah ini juga perlu diingatkan kepada ibu-ibu terutama di daerah pelosok bahwa harus dihabiskan untuk tablet tambah darahnya. Cuma terkadang kalau misalnya kita edukasi misalnya di daerah-daerah desa atau pelosok-pelosok lainnya, untuk mindsetnya masih biasanya mengatakan bahwa ya nggak usah deh minum tablet dari puskesmas atau dari bidan-bidan karena nanti besar anakku, nanti bagaimana begini begitu karena masih mungkin mindsetnya masih kurang untuk mengetahui bahwa pentingnya dan menghabiskan tablet tambah darah untuk kedepannya persiapan persalinan. Kemudian deteksi dini, pantau faktor risiko stunting, KEK, dan anemia, kepatuhan ANIC, pastikan jadwalnya. Inovasi digital untuk kesehatan ibu dan anak, pemantauan digital fase bayi baru lahir. Di sini kita lihat pemberian ASI, pantau frekuensi dan durasi menyusui. Nah ini juga bukan hanya di daerah-daerah desa atau pelosok, tapi justru biasanya banyak yang tidak memberikan ASI pada ibu-ibu yang tinggal di kota atau ibu yang bekerja karena pikirnya tidak apa namanya untuk memberikan ASI langsung biasanya daya isapnya tidak memaksimalkan untuk memberikan ASINya kepada anaknya atau mungkin pengaruh saya sibuk bekerja untuk memberikan ASI akhirnya diberikan susu formula ya itu penting juga untuk kita memberikan informasi bahwa pentingnya memompa ASI saja tanpa terhambat untuk status pekerjaan seorang ibu atau status kesibukan dari seorang ibu tersebut. Kemudian pertumbuhan bayi ada monitor berat badan dan panjang badannya, deteksi masalah early warning sistem untuk gagal tumbuh dan KMS digital. Ganti buku KIA konvensional dengan versi digital. Jadi bukan lagi lembar-lembar yang biasanya dibawa, tetapi dalam bentuk digital, bisa lewat HP ataupun tablet. Kemudian inovasi digital untuk kesehatan ibu dan anak, pemantauan digital fase MPASI. Di sini fase MPASI. Track jenisnya, maksudnya jenis makanan yang diberikan pada saat MPASI-nya, frekuensinya sudah berapa kali ya diberikan, kemudian konsistensi makanannya, keanekaragaman, pantau keragaman asupan gizi, kemudian imunisasi, pengingat jadwal imunisasi lanjutannya, ini penting juga, kemudian milestone development, pertumbuhan, pantau perkembangan motorik dan kognitif pada anak. Inovasi digital untuk kesehatan ibu dan anak, sini sistem terintegrasi untuk pencegahan stunting, dashboard terpusat untuk kumpulan data longitudinal dari semua fase, kemudian analisis risiko, identifikasi anak yang berisiko stunting yang lebih akurat, intervensi target, rancang program spesifik berdasarkan data, kemudian evaluasi program, monitor efektivitas intervensi secara real time. Inovasi digital untuk fokus pada masa persalinan dan nifas. Di sini masa persalinan dan nifas merupakan periode kritis yang membutuhkan pemantauan intensif. Digital pada fase ini difokuskan untuk memastikan kelancaran rujukan. Ya ini yang tadi saya katakan di awal, proses rujukan darurat ini juga membutuhkan akses internet yang bagus, kemudian orang-orang yang menerima atau sistem rujukan yang harusnya menerima untuk rujukan pasien, tetapi bisa jadi tidak ada yang standby di proses rujukan tersebut untuk menerima pasien-pasien yang memang sudah darurat untuk menerima pasien-pasien yang mau bersalin di tempat-tempat rujukan kesehatan. Kemudian memantau kondisi ibu pasca persalinan sehingga menjembatani transisi yang aman dari fasilitas kesehatan kembali ke rumah. Untuk sistem rujukan digital darurat, fungsi aplikasi atau platform yang mempercepat proses rujukan ibu hamil beserta dengan komplikasi, misalnya memesan ambulans, itu bisa lewat aplikasi, mengirim data pasien sebelumnya, mengkoordinasi dengan rumah sakit rujukan. Manfaatnya mempercepat penanganan komplikasi obstetri yang menyelamatkan nyawa. Jangan sampai kita menyanyiakan nyawa 2 orang, ibunya dengan bayinya ya, seperti yang baru-baru kejadian di daerah timur. Pemantauan nifas dan kesehatan mental ibu di sini fungsi aplikasi untuk memantau perdarahan, misalnya jika ada perdarahan, ibunya langsung memberitahu bahwa ada perdarahan, kemudian infeksi dan penyembuhan luka pasca persalinan, Selanjutnya kuesioner terintegrasi untuk screening ini kalau misalnya dibutuhkan kuesioner untuk melihat bagaimana proses menyusui yaitu pasca persalinan. Apakah ibunya tidak terjadi depresi dan lain sebagainya. Manfaatnya deteksi dini komplikasi nifas dan gangguan mental pada ibu. Kemudian aplikasi pemantauan tumbuh kembang anak, fungsinya untuk pencatatan berat badan, panjang badan dan lingkar kepala, pengingat jadwal imunisasi, kemudian panduan milestone perkembangan motorik kognitif dan
Oh
emosi.
iya, enggak apa-apa, Pak.
Platform dukungan menyusui atau breastfeeding. Fungsinya itu biasanya kita berikan video tutorial bagaimana pelekatan yang baik untuk atau menyusui yang baik pada ibu, apalagi ibu yang primiparah yang baru memang punya anak, itu biasanya agak mungkin agak risih atau mungkin tidak tahu untuk memberikan ASI-nya secara maksimal kepada bayinya sehingga bayinya tidak mau menyusu pada ibunya karena mungkin caranya untuk menempelkan bayinya ke payudaranya itu tidak melekat secara maksimal. Forum konsultasi dengan konsultasi laktasi itu pemecahan masalah menyusui ASI kurang atau mastitis terjadi radang pada payudara. Manfaatnya meningkatkan keberhasilan dan durasi pemberian ASI eksklusif. Untuk sistem informasi terintegrasi di sini adalah fungsi basis data terpusat yang mencatat seluruh riwayat KIA seorang ibu dan anak dari hamil hingga balita dapat diakses oleh tenaga kesehatan di puskesmas, posyandu dan rumah sakit. Manfaatnya mencegah hilangnya data untuk memudahkan pelacakan dan evaluasi program. Pemanfaatan big data dan AI untuk KIA itu fungsi prediksi risiko, memodelkan wilayah dengan risiko stunting atau kematian ibu yang tinggi, personalisasi layanan, memberikan rekomendasi konten kesehatan yang sesuai dengan profil ibu dan anak, pemantauan wabah atau melacak penyebaran penyakit yang dapat dicegah dengan imunisasi. Manfaatnya intervensi yang lebih proaktif dan tepat pada sasaran. Ya, di sini kita bisa lihat tantangan dan dari implementasi aspek teknis dan infrastruktur ini yang paling prioritas. Ya, dukungan juga dari pemerintah yang memang perlu, apalagi di daerah-daerah desa ataupun pelosok yang memang membutuhkan akses yang maksimal. Kesenjangan digital tidak merata akses internetnya dan smartphone di daerah terpencil yang seperti daerah-daerah pelosok. Kemudian interoperabilitas atau kesulitan terintegrasi antara sistem dan aplikasi yang berbeda. Jadi biasanya error sistem untuk rujukan sehingga untuk merujuk pasien itu agak kesulitan juga. Jadi dikira tidak ada pasien yang mau dirujuk ke rumah sakit tipe yang tertinggi, ternyata ada rujukan karena tidak ada integrasi atau sistemnya error. Kemudian keamanan cyber, perlindungan data privasi ibu dan anak. Literasi digital, kemampuan ibu dan keluarga dalam menggunakan teknologi ini juga perlu kita dampingi, walaupun misalnya si ibunya tidak terlalu mengerti terkait kemajuan digital, tetapi biasanya kita ajak keluarganya atau orang terdekat yang memang mengerti atau paham terkait aplikasi yang penting untuk kesehatan ibu dan anak. Kesiapan tenaga kesehatan perlunya pelatihan untuk mengadopsi alat digital. Nakes pun itu perlu ada pelatihan atau perlu diberikan pelatihan, apalagi nakes-nakes yang ditempatkan di daerah-daerah terpencil atau pelosok itu lebih penting diberikan pelatihan untuk terkait semua pelayanan kesehatan yang memang ada kaitan kepada kesehatan ibu dan anak. Budaya dan kepercayaan, ini juga budaya dan kepercayaan kita agak kesulitan untuk memberikan semacam tindakan aplikasi karena biasanya budayanya si daerah A dan B itu agak berbeda, kemudian kepercayaannya masih mengarah ke kepercayaan dahulu yang istilahnya dia tidak mau mengakses digital, tetapi katanya enggak usah karena nenek saya dulu itu walaupun tidak memeriksa kehamilan itu juga semua lahir dengan normal, lahir banyak anaknya sampai 10, 12 malah. Tetapi ya itu yang perlu kita kikis sedikit demi sedikit untuk kepercayaan dari daerah, yaitu memberikan edukasi secara berkelanjutan, berkesinambungan kepada orang-orang yang masih kepercayaannya masih seperti itu. Strategi mengatasi tantangan di sini adalah kebijakan pemerintah yang paling prioritas atau paling utama itu membuat regulasi dan standar untuk e-health dan m-health. Pendekatan multisektor itu kolaborasi karena bukan hanya nakes saja yang istilahnya berpeluang dalam memberikan strategi electronic health ini, tetapi seluruh sektor yaitu Kominfo, swasta, dan NGO. Desain yang user-centric, aplikasi yang mudah digunakan dengan bahasa lokal. Jadi bahasa-bahasa yang mudah dipahami, bukan bahasa-bahasa yang sulit, apalagi berbahasa yang di luar dari bahasa Indonesia misalnya. Edukasi berkelanjutan, pelatihan bagi kader-kader posyandu dan tenaga kesehatan yang memang perlu diberikan pelatihan supaya pada saat dia memberikan atau mensosialisasikan digital yang untuk kesehatan ibu dan anak lebih mudah karena sudah diberi pelatihan oleh kader-kader langsung. Studi kasusnya, di sini kesuksesan aplikasi misalnya untuk contoh adalah Momcare di Indonesia. Di sini platform terintegrasi untuk pemantauan kehamilan risiko tinggi. Contohnya hasil hipotesis berdasarkan tren penurunan ada 15%, keterlambatan rujukan dan peningkatan kepuasan ibu. Faktor kesuksesan integrasi dengan puskesmas dan pelatihan bidan yang memadai. Masa depan inovasi digital biasanya menurut AI Chatbot untuk pelayanan kesehatan 24/7, kemudian Black Hand untuk keamanan rekam medis virtual atau VR, untuk edukasi kehamilan dan pelatihan tenaga kesehatan, Internet of Things atau e-out dengan perangkat yang saling terhubung di rumah. Untuk kesimpulannya, inovasi digital memiliki potensi besar untuk merevolusi program KIA. Berbagai inovasi telah terbukti meningkatkan akses, kualitas, dan efisiensi layanan. Keberhasilan implementasi membutuhkan pendekatan yang holistik dan menyeluruh yang mencakup seluruh aspek teknologi, regulasi, dan SDM-nya sendiri atau manusianya itu sendiri. Kolaborasi ini juga penting karena kita perlu berkolaborasi dari segala sektor atau pihak yang terkait untuk mendukung inovasi-inovasi tersebut. Yang semua pihak kunci untuk mewujudkan KIA digital yang inklusif dan berkelanjutan. Ini ada beberapa daftar pustaka. Mungkin itu saja dari saya. Terima kasih Ibu Rizky, saya stop share.
Terima kasih Bu Riana. Terima kasih atas pemberian materinya yang sangat ini ya, ternyata banyak sekali aplikasi yang tersedia gitu yang bisa digunakan begitu. Mungkin peserta sudah ada yang ingin bertanya, dipersilahkan. Peserta ada yang ingin bertanya, dipersilahkan. Bisa raise hand atau bisa drop pertanyaannya di kolom komentar ya. Dipersilahkan.
Bu Rizky.
Ya, sambil menunggu mungkin Bu izin bertanya. Ini kan sebenarnya banyak sekali tadi aplikasinya. Bagaimana menurut Ibu tantangan ini begitu kalau misalkan banyak aplikasi seperti itu dan mau digunakan? Oh, ada pertanyaan Bu dari Bu Akwartusi. Dipersilakan
Halo Mbak
Bu.
Tuti.
Dipersilakan Bu Tuti.
Ya, terima kasih Bu Rizky. Nanti habis ini Bu Rizky gitu ya. Ya,
Silakan.
menyapa Bu Nur, selamat siang Bu Nur, see you lagi, kita ketemu lagi Bu ya, tapi tetap
Iya.
masih ruang Zoom ya. Kapan nanti ini kita bertemu?
Kapan lagi ke Makassar Mbak
Jawa.
Tuti?
Iya. Siap, ini mau sedikit sharing aja Bu Rizky. Tadi juga Bu Nur menyampaikan bahwa ada terkait penggunaan big data ya, di mana kita bisa memprediksi kemungkinan kejadian dari penyakit yang berkaitan dengan ibu dan anak. Tapi tadi saya mungkin agak sedikit terlewat terkait dengan bagaimana cara kita atau tantangan penggunaan big data dan cara kemungkinan bisa untuk menghandle big data. Mungkin Bu Nur Sriana punya sedikit inspirasi ini. Silakan.
Ya, baik. Karena biasanya kalau misalnya kita memberikan beberapa data, apalagi data-data pribadi, itu yang perlu juga kita lindungi. Jadi biasanya kalau misalnya pihak puskesmas ataupun rumah sakit itu menginput data-data pribadi dari pasien atau ibu hamil atau anak itu, memang betul-betul ada semacam kode khusus ya, misalnya untuk pasien A supaya tidak bisa diakses oleh orang lain ataupun orang-orang yang tidak memegang dari data-data tersebut. Ya, mungkin itu saja kalau misalnya untuk masalah big data-nya. Karena mengingat kalau kita menginput sekarang masalah data-data dari pasien itu semua eh, jangankan pasien, bahkan sekarang kalau kita memasukkan beberapa aplikasi yang notabene bukan untuk nakes, nakes itu dapat diakses. Jadi mungkin ada kode khusus yang misalnya diberikan diinput masuk ke dalam big data dari rumah sakit tersebut.
Siap. Terima kasih
Iya,
Bu Nur Sriana atas insight-nya. Dan mungkin juga, siapa tahu nanti ya, karena memang big data itu tantangan juga ya Bu ya, untuk
iya,
dunia kesehatan. Mungkin nakes-nakes nanti akan lebih banyak ya kita bekali ilmu-ilmu terkait penggunaan atau pemanfaatan big
iya,
data. Sayang
baik.
banget ya, data yang banyak yang punya biasanya orang bukan pemerintah Indonesia.
Ya, itulah Mbak. Makanya sekarang bahkan email pun bisa
Lepas ya.
diakses, ya, diretas. Bahkan kita pun ini yang sebagai notabene orang yang punya pendidikan yang lebih dari masyarakat di pelosok itu, bahkan kita juga bisa diakses dana. Cuman ya bagaimana kita merefresh kalau misalnya untuk data sendiri, mungkin merefresh password, merefresh beberapa kode-kode dari email itu supaya tidak bisa diakses langsung dari orang-orang yang tidak bagus untuk meretas data kita.
Siap. Terima kasih Bu Nur Sriana. Saya
Ya,
kembalikan ke Bu
sama-sama.
Rizky.
Terima kasih. Berarti ya Bu, ini mungkin yang Bu ini kan banyak tadi ya Bu aplikasi yang digunakan sebenarnya. Tapi saat kita ini kan biasanya dia tidak terintegrasi jadi satu Bu ya. Nah itu juga permasalahan yang sering kami temui di lapangan. Misalnya kita minta data ini tapi harus ke dulu ini dulu. Mau minta data ini dulu ke ini dulu. Itu kan Bu ya.
Iya.
Bagaimana menurut Ibu? Menurut Ibu, mungkin Ibu sudah sering menggunakan beberapa aplikasi yang sudah Ibu jelaskan tersebut.
Maaf Bu, putus-putus suaranya.
Putus-putus Bu sekarang masih putus-putus Bu.
Iya, coba.
Masih ya.
Ya, oke, bagus.
Ya, izin. Kan banyak Bu ya aplikasi Bu ya.
Iya.
Tapi itu pada saat kita in data, kemungkinan itu tidak terintegrasi menjadi satu sehingga pada saat kita membutuhkan data tersebut kita harus ke ini dulu, ke sini dulu, menunggu si ini, menunggu si ini. Begitu. Bagaimana menurut Ibu yang mungkin sudah menggunakan beberapa aplikasi, bagaimana menurut Ibu mengenai tantangan tersebut?
Bagaimana iya, saya perjelas sedikit bagaimana untuk menginput apa data.
Masih putus-putus ya Bu
Iya,
suaranya.
masih putus-putus.
Nah, sepertinya ini jaringan.
Iya,
Jadi karena itu di Bu, datanya satu saat apa beda aplikasi Bu,
ya
kadang kan
boleh.
tidak terintegrasi jadi
Iya,
satu. Sehingga pada saat kita mau meminta data ini harus saja ini, harus menunggu si ini. Begitu Bu biasanya. Nah, ini bagaimana menurut Ibu jika di apa kita menemui tantangan seperti itu, Bu? Apalagi Ibu sudah menggunakan mungkin beberapa aplikasi tersebut yang sudah dijelaskan tadi.
oh ya baik. Mungkin saya dengar-dengar tidak terlalu jelas, maaf ya. Baik, Bu Rizky, kalau untuk kan ada beberapa pada saat kita membuka satu contoh, membuka satu aplikasi dan untuk mengisi beberapa item data-data dari ibu hamil atau anak tersebut itu memerlukan data ini ke sana dan data yang lainnya untuk ke sini. Baik untuk biasanya untuk beberapa misalnya satu aplikasi di dalam satu aplikasi tersebut biasanya sudah terinput istilahnya masuk ke dalam tidak perlu ke sana kemari, bahkan itu terintegrasi dari misalnya data NIK-nya saja kita kasih masuk, kemudian apakah setelah NIK-nya kasih masuk, kan biasanya kalau NIK itu beda-beda dari setiap orang, beda kalau nama misalnya Nur itu banyak sekali kalau kita akses di Nur, tetapi kalau kita input NIK-nya itu biasanya hanya 1 orang untuk per 1 NIC, dan untuk memberikan masuk beberapa data-data itu biasanya kita cukup biasanya memasukkan NIC dan mengakses di dalam NIC tersebut sudah keluar biasanya data-data yang diperlukan tanpa harus kita ke daerah sana dan daerah sini ataupun ke pihak rumah sakit ataupun ke puskesmas begitu mungkin.
Iya. Terima
Ya,
kasih banyak Ibu Nusriana.
iya
Izin
baik.
sebelum kita akhiri, Ibu, mohon maaf karena waktu, izin kami share sertifikat appreciation untuk Ibu NS Nusriana MK. Terima kasih
Baik.
hari ini sudah bergabung bersama kami, Ibu, pada
Ya, baik.
kesempatan
Terima
hari ini.
kasih, Bu Rizky,
Ya,
Mbak
semoga Ibu
Tuti,
sehat terus.
dan yang lainnya. Ya,
Dan bisa
sehat-sehat.
bertemu lagi di lain kesempatan, Ibu.
Insya Allah, Bu.
Iya.
Siapa tahu bisa ketemu langsung di Makassar, hubungi saya
Iya,
saja,
pada
Bu.
satu pulau ya, Bu. Siap,
Siap,
Bu,
siap,
siap.
siap. Nah,
Terima kasih
jangan,
banyak, Ibu Nur.
baik. Terima
Triana,
kasih.
baik.
Izin.
Izin ya, silakan Ibu. Ya, baik, kita sudah berada di akhir penghujung dari sesi pertama. We have reached the end of this insightful session. Today we learned that improving maternal care requires a new thinking that encompasses both the physical environment and the community and the internal psychological environment of the mother. The use of AI to help early detection, also the digital innovation for maternal health care is also very helpful. So before we ending, I would like to express my sincere gratitude to once again to our phenomenal speakers, Dr. Hana Chen, Dr. Folti Satafori, Professor Dr. Charmini, and Bu Nur Sriana MK. Thank you all for enriching our discussion with your cross-sectoral expertise. We sincerely hope you have found this session insightful. We wish all 4 of our speakers the very best in your ongoing research and endeavors. Crucially, please be informed that attendance link for all participants will be shared during the upcoming session 2. Jadi link untuk absensi akan diberikan pada sesi kedua. Selanjutnya sesi kedua will commence shortly after and will be led by our next esteemed moderator, Mrs. Akwati Tri Damayanti, SST MKM from Speakers Mambawu Surakarta. Hello Bu Tuti.
Halo, Bu
Halo,
Rizky. Semangat
Okay,
pagi ya. We have the morning spirit,
semangat pagi.
even though now in this afternoon.
Correct. Allow me to share screen for the curriculum vitae of Miss Akwati Tri Damayanti. Beliau lahir di Bandung dan sekarang pendidikan terakhir S2, namun sekarang sedang kuliah ya Bu, S3 Ilmu Kesehatan Masyarakat di UNS. Kita doakan beliau semoga sukses S3-nya dan dilalui tanpa ada hambatan.
Amin.
Kemudian beliau juga merupakan seorang reviewer dari beberapa jurnal yang terindeks Scopus Q1 dan Q2. Beliau merupakan afiliasinya di Sekolah Tinggi Kesehatan Mambawu Ulum Surakarta. Banyak sekali beliau mengikuti kegiatan konferensi dan seminar workshop, dan apalagi publikasi beliau saya scroll sampai habis minggu ini sekali, alhamdulillah. Selanjutnya ini kepada Ibu Akwati, mungkin saya serahkan untuk sesi kedua. Saya izin pamit. Thank you for the opportunity today that given to me to become moderator for session 1. I'm signing off. Thank you and good day.
Thank you so much, Ms. Rizky Febrianti, for leading the first session of the symposium and also the discussion from our outstanding international and national speakers. Okay, ladies and gentlemen, our honorable participant. Now, I will inform you due to the varying time of Indonesian time zone. So the committee give you suggestion to take your time for praying, zuhur praying, and also for your lunch based on your times. So we will continue to the next agenda of the second session for the symposium. Ya, terima kasih Bu Rizky sudah memandu sesi yang pertama. Dan tentunya kita akan melanjutkan di sesi yang kedua. Panitia menghimbau tentunya karena ada perbedaan zona waktu ya di Indonesia. Kita terbagi dalam 3 zona waktu, saya dan Bu Rizky saja berbeda 1 jam. Sehingga panitia mempersilahkan teman-teman untuk beristirahat, sholat, zuhur, ataupun makan siang disesuaikan dengan zona waktu masing-masing. Dan untuk konferensi tetap akan kita lanjutkan kepada sesi yang kedua. If you miss some of this conference or some of the material, we will give you the material in the group or you can see our recorded. So jikalau teman-teman nanti agak tinggal atau mungkin materi yang tadi belum sempat diikuti, tentunya rekaman nanti akan disiapkan dan juga materi akan kami share atau akan kami berikan kepada para peserta tentunya. Okay, ladies and gentlemen, our honorable participant, we will continue to the next, our national speaker, Miss Verina Damayanti. I will say hello first to Miss Verina. Halo Mbak Verina.
Halo.
Oke, sehat Mbak? Alhamdulillah sehat. Ini live dari mana Mbak? Mungkin tidak, saya kurang terdengar Mbak.
Ya.
Ya mungkin boleh lebih didekatkan speakernya.
Oke,
Halo,
baik.
halo.
Sudah?
Iya, siap terdengar Mbak. Dari mana ini Mbak live-nya Mbak atau Zoom-nya? Dari?
Kendal.
Dari Kendal. Oke, dari Kendal. Satu zona waktu berarti dengan saya ya. Sekarang masih jam 11.17.
Iya.
Oke, sebelum memulai izinkan saya untuk membaca sedikit ya Mbak Verina terkait CV ya kan, kalau tidak kenal maka kita kenalan. Kayak gitu ya. Okay, ladies and gentlemen, before we continue our agenda to the next speaker, I will read a short curriculum vitae to our national speaker, Miss Verina, because I think not all of you know Miss Verina, even me, so we will know more ya. Kalau tak kenal maka kita akan kenalan. Okay, her full name is Apoteker Verina Damayanti. Actually, we have in the same age, Miss Verina. Saya senang bertemu dengan teman seangkatan ya, sepantaran begitu. Now, Miss Verina is the staff in the research unit in Stikes Kendal since 2024 until now. So this is the personal contact and also the personal address. So you can have the contact if you have some interest for the research or maybe for some project of course, for the education. Miss Verina has been graduated from Universitas Ahmad Dahlan for Magister in Pharmacy, and also she have a linear knowledge about a pharmacy with majority all of the pharmacy since 2016. And also as a staff of the research unit, she have a lot of the research and a study project. So, okay, ladies and gentlemen, now the time for the Miss Verina to introduce and also to deliver the material. To Miss Verina Damayanti, the time is yours.
Thank you very much. Mohon izin untuk share screen terlebih dahulu.
Oke, siap, sure. Okay, Miss Verina, I can see your PowerPoint presentation now. Excuse me, Miss Verina, your sounds, yes, yours. I think your sound is not stable.
Okay.
So maybe,
Stable?
yeah.
Oh.
Okay, now it's better.
No?
Ya, sekarang bagus tapi terputus, Bu. But
Oke.
the connection is unstable. Maybe you
Ini
can try. Yeah, it's
apa bisa
better. I
dengar?
think without,
It's more
yeah,
stable.
more better, more stable, and also I think it's better for you to use as to don't use your heads.
Okay, that's it.
Okay. Maybe you can make it a full screen first, Miss Verina.
Yes. What?
Can you make a full screen for your PowerPoint?
Okay. Wait a few minutes.
Okay, thank
Yes.
you.
Yes. Okay, thank you. Yes, I'm honored to present this today. This topic is drug using a material pregnancy. Yes. Okay. Medication used in a pregnancy is highly complex because it involves the health of two individual, the mother, and the developing fetus. Today, we will explore the scientific basic risk, pharmacological consideration, and clinical decision-making principle involved in prescribing medication during pregnancy. This epidemiology in clinical practice, pregnant women often experience a variety health issues. Studies show the over 80% of pregnant women use the list of medication and many take more than 3. The medication may be used the pregnancy-related symptoms like nausea, vomiting, pain, or swelling, and of chronic disease such as hypertension, diabetic, asthma, and infection. Because the every medication can potentially reach the fetus, understanding drug safety becomes essential. Your goals to optimize maternal health without exposing the fetus to unnecessary harm. This is embryonic fetal development. To understand drug affect the fetus, we must first understand the fetal development. Human fetal development lasts approximately 38 weeks and divided into three semesters. Within the time frame, we also categorize development into the 3 critical biologic stage. First is embryonic stage, and the second is embryonic stage, and the last is fetal stage. Each stage has unique sensitive to drug, meaning the timing to exposure is just important to the nature of the drugs. This is embryonic stage, contraception day 70, cell to potential, and the demix drug to replace, and kemudian ada embryonic from day 18 to 20. After contraception, measure the formulation, orthogenesis, and the fetal from the egg to 30 egg organ completion and the brain development. The first is pre-embryonic stage. The pre-embryonic stage begin contraception, lasts until the 70. At this stage, the embryonic consists of two potential cell, meaning each cell candidate develop into the complete organism. If the medication or toxin damage, then this cell will typically see an all or nothing response. The embryo may completely recover to the lasting effect, or the pregnancy might fail and result in miscarriage. Structural malfunction do not usually occur this stage because the organ development has not yet begun. And the second stage is embryonic stage, the most vulnerable period in the pregnancy. Embryonic stage is the organosis major occurs, such as the brain, heart, spine, limbs, and the facial structure are formed. Exposure to teratogenic during the period can lead to structural birth defects, dyspogenesis, neural tube defects, cardinal abnormalities, and also in the time when many women are unaware the pregnancy make an unintentional exposure likely. And the final stage is fetal stage. Fetal stage organ continue to grow and mature. Drug exposure The time is likely to cause structural abnormalities, but still lead to growth restriction, impact neurologic development, function abnormalities, physiological disrupt, maternal labor, and natural complication. Understanding this helps clinical avoid to limit fetal exposure during clinical development process. What about teratogenesis? Teratogenesis is any substance capable of causing fetal malformation and developmental impairment when taken during pregnancy. Interesting, around 3% of drugs are coming to teratogens. However, because the stakes are so high, even drugs with a proven effect must be evaluated carefully about timing, dose, duration, and the fetal genetics all influence the severe teratogenic risk. What is mechanism of teratogenesis? Teratogenesis is infecting with cell proliferation and disturbing DNA synthesis or repair, affecting nourish supply to fetus, and the altering placental function, and the triggering oxidation stress, and charging fetal gene expression, their epic effect. Certain genetic variant fetus might increase susceptibility, explain why not all fetus exposed to the same drug develop abnormalities. This is drug transfer drug to the placenta. Yeah, this placenta does not act the perfect barrier. It's not like a selective filter, right? It's a most selective filter. The most cross positive dispersion factor the increased placental transfer include high solubility. High lipid solubility, low molecular weight, low protein binding, non-ionized state at physiological pH, and large molecules such insulin, heparin do not easily cross the placenta. Weakly basic drug might accumulate in the fetal circulation in the ion trapping. This is lipophilic or nothing ionized drug cross placenta more easily than polar. Weakly basic drugs are trapped in the fetal circulation. Drugs with high molecular weight have difficult cross in placenta, like insulin and insulin. Kemudian, and then clinical example is flecainide. This flecainide, one interesting example is flecainide is a arithmetic drug. Yes, arithmetic drug through the cross placenta. This is beneficial when treating fetal tachycardia. This illustrates the placenta drug is not always harmful. It can be therapeutic when carefully managed. Drug effect on fetus, the effect medication exposure different dramatic dependent of the stage. Pre-embryonic stage is all or nothing response is fetal death. And the next, the pre-embryonic stage. And the next is embryonic stage is structural malformation, most critical period. And the next is a fetal stage is functional toxicity, physiological effect, and the growth retrosdiction. Example include is ENSIDE, the causing premature close, and the ducts arterius in the late pregnancy, or phenobarbital, causing congenital anomaly in the early pregnancy. This is idionic drug reaction. This is a drug effect predictable. Other idiostatic, meaning is they are not dose dependent. They are fetal enzymatic genetic different, and they may involve immune medicated or metabolic pathway. And the unpredictable reaction highlight why even drug considered safe should be used with cognitive pregnancy. This is a pharmacokinetic profile change. The first is absorption. Yeah, pharmacokinetic. You can talk about ATMA. This is absorption. Absorption, pregnancy altered absorption is medication do a delay gastritic empty, reduce intestinal motility, and then increase gastritic pH and the nausea and the vomiting. The change might affect oral bioavailability, requires dose adjustment or alternative routes in the administration. It is a clearance with a few weeks of pregnancy. Grade filtration rate increased by 50%. Clearance of drug primarily expressed by kidneys is lithium. Some beta-lactam increased. This beta-lactam is antibiotic, and the maintenance dose should be increased, and metabolic increase due to enzyme induction by progesterone, but individual effect vary and difficult to predict. This metabolism or methadone and phenytoin increase the third semester, so the dose need to increase. However, theophylline metabolism is decreased, required a dose reduction. And the next is distribution. Maternal blood volume increase abnormality 40 to 50%. The expand to volume of distribution, especially to hydrophilic drugs. As a result, loading dose might need to be increased. Peak concentration might be lower, and additionally, plasma albumin decrease, increasing of the free fraction of protein-bound drug like phenytoin or warfarin. And the next is metabolism. Hormonal change, especially increase in estrogen or progesterone. Alter hepatic enzyme activity can be increase the metabolism drugs such as phenytoin, methadone, and the decrease of metabolism is theophylline because the change vary amongst individual therapeutic drugs. Monitoring becomes essential for the medication. This is FDA category for drug use in pregnancy. This a category, the control studies, and the woman failed to demonstrate a risk to the fetus in the first semester and possibility to fetal harm remote. And B category, other animals studies do not indicate a risk to the fetus, and the no control studies in the pregnant woman or animal studies have indicate fetal risk, but control studies in women fail to demonstrate to risk to the fetus. And the next is C categories. Either animal studies indicate a fetal risk, and are no control studies in a woman, or there are no available studies in the woman on animal. And the D categories, there is a positive evidence in the fetal risk, but my certain situationally, there are no benefit outweigh the risk. And the next and the last is X categories. There is a different fetal risk based in animal, on human, on a basic human, on experience that risk clearly outweigh any benefit to a pregnant woman. These drugs know the therogenics example for the ACE inhibitor, alcohol, androgen, anticonvulsant, antineoplastic, cocaine, and the iodine, lithium, and the thiodomine, and warfarin. Now, drug suspect teratogens. Some drugs have limited inclusion evidence, but might still pose risks. Example include certain benzodiazepine, it's a diazepam, estrogen, metamizole, quinolones, oral hypoglycemic, photogastric, and triacyclic antidepressant. This is a drug with non-teratogenic adverse effect. Not all harmful fetal effect involves structural abnormalities. some drugs cause fetal withdrawal, respiratory depression, neonatal hypoglycemic, adrenal suppression, fetal anemia. For example, is chronic use opiates can lead neonatal withdrawal syndrome. This drug is antithyroid effect agent. Anti-glucose aspirin, barbiturate, beta blockers, benzodiazepine, kind, and each other. This health problems during a pregnancy. This pregnant woman frequently face medical issues include anemia, constipation, GERD. GERD is gastrointestinal reflux disease, and nausea, vomiting, gastrointestinal diabetes, and constipation, and hypertension or preeclampsia and eclampsia. The first is anemia. Anemia is there's common types include physiological anemia, occurs due to increased blood volume during pregnancy. And the next is megaloblastic anemia, occurs due to folic acid deficiency. Give a supplement. This is folic acid for megaloblastic anemia. And then iron deficiency anemia must be give iron supplement. Iron supplement can be taken with meals to reduce stomach irritation. And the next is constipation. This is constipation result from a slow gastrointestinal motility due to hormonal changes. Treatment includes hydration and high fiber diet and self-lactative like bulk forming agent. Yeah, this constipation to decrease intestinal peristaltic movement. Therapeutic include physical exercise, include fluid, high fiber intake is laxative are needed. Choose the increased stool bulk or stool softener as they are not absorbed. Strong laxative can be still ultrate constriction. And the next is GERD. GERD is becomes coming late pregnancy due to hormonal effect to the lower esophageal structure. This management will include eating small, frequent meal, avoiding spicy or aged food, using antacid as first line therapy if had to blocker such as cimetidine, ranitidine are generally can be safe. Yes, this for this GERD in pregnancy, you can take cimetidine or ranitidine and sucralfate can be used. And the next is nausea and vomiting. Nausea affect up to 70 to 80% of the pregnant woman. Initial therapy include the dietary modification. Ineffectiveness pharmacologic therapy can be used dimethyl and pyridoxine 10 to 25 milligram per day. This is pyridoxine. This pyridoxine very helpful in the reduction nausea and vomiting in the pregnancy. And the next is hypertension during pregnancy. Clinical manifestation, edema, hypertension, and the impotent proteinuria starting at weeks 20 of the routine antenatal care. Preeclampsia usually occur in preeclampsia therapy is adequate. Nifedipine is usually used in hypertension management, while magnesium sulfate is used for seizure management. This pregnant woman, this is a key point is medication should be given to pregnant woman if the benefit outweigh the risk to fetus. Avoid the medication used in the first trimester. If medication is necessary, choose the safest medication. Use the lowest effective dose for the shortest possible duration, because with a patient to use medication for chronic illness if they wish to become pregnant. This is a principle of safe prescribing pregnancy. Use medication will benefit clearly with a quick increase, avoid medication during the first semester, just drug with a stable safe, use the lowest effective dose for the short time, and high pre-consultation counseling in the patient with chronic disease. This is drug safe for during pregnancy or uh, 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 during lactation. This is a drug class for analgesic. You can acetaminophen, or in the lactation you can acetaminophen to coagulant heparin, and the anticonvulsant phenobarbital, anti-diabetic. This is safe for during pregnancy, insulin, antihypertensive methyl-dopa, and then anti-infection penicillin. This corticosteroid is prednisone, and the decongestant is oxymetronidazole drop, and the GI protection is MGOH or ranitidine on sucralfate. And the laxative or dose donor, you can use pilicidum or Ducosat. This reference you can search is Medscape. Medscape in the Google, you can search this is Medscape. Medscape can be alternative choice for recommendation, pregnancy and the consideration, breastfeeding and maternal medication recommendation for drug in the 11 WHO model list and essential drugs. And this BNF is books. Yeah, you can books. You can see the pregnancy and the appendix. You can see this is digoxin, what small and harm is. This is drug, and the you can use this. Yes. Okay. Okay. Thank you very much, Miss Aquatuti. Time back to you.
Yes, thank you so much, Miss Verena. You can call me Tuti because I know it's really hard to spelling my name.
I'm so sorry.
No problem, no problem. It's really correct, but I think a lot of the people it's really hard to spelling my name, and I don't have an endorse for any product. So even though my name is really close to one of the
I'm
most
so
famous,
sorry.
yes, mineral water product. Okay. Okay, ladies and gentlemen, you can ask rather than in Indonesia. It's okay if you want to ask in Indonesia, or if you want to have a discussion to the international speaker with Indonesia. I will try my best to translate in English. Okay, Miss Verena, we have one question in the chat and also one people raise hand. So I will give the opportunity, or two people. I will the opportunity to people who raise hand. Miss Tri Nur Aziza. Okay, Miss Nur Aziza, you can open your video. Okay. Yes, Miss Nur Aziza, you can deliver your question.
Okay. Do you hear my voice?
Yes, I can hear your voice. Okay.
Yeah, I'm Aziza. My name is Aziza, and I'm from Sikastela. So, and I'm also a practitioner in pharmacy. My question is, some patients come to the pharmacy and want to do self-medication. And there are some pregnant patients with constipation who want a rectal tube. So what should we do? What should be advised being a pharmacist? Thank you. That's all.
Okay, thank you, Miss Trinur Aziza. Is really already clear, Miss Verena, for the question?
Okay.
Yes.
Okay. Thank you, Miss Aziza. This rectal tube can be used during pregnancy, right? But must done very carefully and preferably under the supervision a healthcare provider. Yes, this is carefully because I'm so sorry. This because stimulation rectal may potential trigger contraction. Yes, this is uterine contraction, especially to late pregnancy in a woman history preterm labor. This is also risk rectal injury and infection in a tube instead too deeply and without proper hygiene. That's all.
Yes. Okay, Miss Miss Aziza, is it already clear for the answer, or you want to have a discussion again?
Yeah, thank you.
Okay, thank you so much. Okay, we must be careful for the girls. Yes, they can induce the preterm labor because they can make a contraction in our lower abdomen, especially. Okay, before I will continue to Miss Niken Yuniar, I will read the question from the chat Zoom. Come from Miss Surnik Cahyawati. I think this is two questions. The first question is, Miss Verina, can you explain the absorption drugs in pregnant women for free drugs or drugs that we can buy in the store with the green or the blue labeled can actually affect of the pregnant woman, and how long the pregnant woman should take the free drugs medicine before they come to or they seeing a health professional? Okay, is this clear?
For Sunik Cahyawati, right?
Yes, Miss Sunik Cahyawati, I'll give you two questions if I'm not have a misunderstanding. The first question is for talking about absorption drugs, free drugs, or the drugs can we buy in the store. And then the second about how long we can take the free drugs before we come to the medical professional. Ya, ini saya lihat ada dua ya pertanyaannya. Pertama itu bagaimana absorpsi dari obat-obatan bebas ya yang dapat kita beli gitu di warung terutama untuk ibu hamil, dan berapa lama sih kita bisa ya sepertinya untuk untuk meminum obat tersebut sebelum ke petugas kesehatan. Oh, ini kalau saya bidangnya sukanya kayak gini orang. Ya dikit-dikit pusing beli aja obat warung gitu. Tahu kalau hamil gitu ya.
Iya,
Okay,
betul,
Miss
betul,
Verina.
betul.
Yeah,
Okay.
maybe if yeah, I think it's very important information to all of this participant. If you want to mix your answer in Indonesia, is it okay?
Okay, thank you. Okay, thank you. Observation of the over-counter medication in the pregnant woman is generally the same as adult, but infant by pregnancy change slower stomach emptying due to increased progesterone and a more alkaline stomach pH, making addictive medication more difficult but absorbs increased blood volume, making medication more dilute and possibility of drug transfer across the placenta. All drug medication labeled green or blue are generally safe according to direct for use. For over-the-counter medication that are generally safe include those labeled green, such as paracetamol or mild antacid, and label blue when used direct. Pregnant women may take over-the-counter medication for a maximum 2 or 3 days for mild symptom and should see immediately medical attention if symptoms do not improve with 2 or 3 days with a high fever or new side effect appear. Okay.
Okay, yes, I think it's clear. Miss Sunik is already okay. Ya, Bu Sunik, bagaimana? Ya, jadi aman ya kalau misalkan ya paling nggak ikutin labelnya sampai 3 hari ya Bu Verina.
Iya, 2-3 hari. Jadi nanti baru kalau memang belum baik baru nanti bisa ke dokter seperti itu.
Okay,
thank you.
Yeah. Okay, thank you, Miss Sunik, and also Miss Verena for the answer. And I know one of the most important information based your question is if you have a fever, you must. Jadi sebelum 3 hari kalau udah ketemu gejala lain seperti demam, mungkin bisa menemui tenaga kesehatan. Just okay. So if you use the free drugs and then you have, or maybe your symptom is getting worse, you must come to the health professional before the 3 days maybe. Okay, Miss Verina, we have a two-person again, raise hand, and then the next, I will give the opportunity to Miss Niken Yuniar. Yes, Miss Niken Yuniar, you can open your microphone and ask directly, please.
Yeah, thank you, Miss Tuti. Yeah, Miss Verina, thank you for your topic. It's very interesting for me. Maybe my voice is clear. Yeah, okay. Because I'm nursing in mental health, yeah. So I want to ask about how about the woman pregnant in schizophrenia? This is there is a safe for consumption drug, or there is a special drug for the pregnant woman in schizophrenia. Okay, enough.
Okay, thank you, Miss Niken. Miss Verena is already clear for the question, or maybe you can want to ask something again.
I'm so sorry. Once again, please.
Oh, mungkin the medicine ya, how
Sinyal
take the
saya,
medicine ya. Oke, jadi
Maaf ya, Bu.
mungkin maybe you can repeat again the question, Miss Niken.
Ya, medicine ya. Because of your topic is drug, so I follow drug
Biar nggak
ya.
serem ya, biar nggak serem aja sih sebenarnya Bu, kalau kata saya.
Follow aja drug gitu tadi. Sebenarnya harusnya medicine ya. Oke.
Biar nggak serem ya.
Maybe Miss Verina, I want to ask about how about the woman pregnant in schizophrenia? There is a special medicine or maybe safe for consumption the medicine as usual. Yeah,
Jadi you're asking about the medicine can save
medicine.
to reduce the
Yes,
symptom of the schizophrenia
yes,
if they doesn't have a consultant, something like that.
yeah. Or maybe there is a special medicine
Okay.
Yeah.
for the pregnant woman.
Okay. Yes, pregnant woman in the schizophrenia, right? Yes, pregnant woman in the schizophrenia can should receive treatment, but the choice of medication must be individualized. Most commonly, doctor use second generation antipsychotropics such as quetiapine, olanzapine, on risperidone. I'm sorry, risperidone, because they have a most safety data in a pregnancy in the same class is haloperidol in the first generation antipsychotropic is also used considered relative safe. However, the best drug dependent of the woman past response, side effect, and severity of the symptom. Stopping treatment in the usually not recommended because uncontrolled schizophrenia can be more harmful both mother and the baby in the medication and itself. All decision must be with psychiatric and obstetrician ensure safe monitoring throughout the pregnancy. That's it.
Okay, Miss Niken, is already clear?
Yes, clear. Safe berarti ya. Safe
Yeah,
semuanya.
safe.
How about the
Safe
dose?
semua, Ibu.
The dose?
Gimana, Bu?
The dose? This
Oh,
is
the dose.
decrease or decrease or same as usual?
No. Masih tetap sih Bu untuk dosisnya untuk si obat-obat tersebut. Jadi masih tetap untuk dosisnya, cuma memang untuk monitoringnya harus lebih ketat untuk penggunaan pada ibu hamil dan karena tadi itu kalau dia berhenti secara tiba-tiba itu akan berbahaya untuk si ibu dan si janinnya, begitu Ibu.
Yeah, okay, thank you, Miss Verina.
Thank you, Miss Verina, for your question. And also our committee, Mr. Dona, raise hand. One hand, Miss Dona, or two hand, Mr. Dona. If you raise your hands, two of your hands, it means that you are
I'm right hand.
Okay, Mr. Dona, I'm so sorry because your name is really similar to the female. This is why the first time I call you Mrs. Okay, Mr. Dona, you have a question. Maybe you can ask directly to Miss Verina. Okay, please.
Thank you, Miss Aqua. Sorry, Tuti. One of the slide make me interesting. That maybe it's controversial or something. I don't know, but I need to make sure that one of your slide that you explained about the non-teratogenic substance, maybe it's a nicotine. Is that true? That nicotine is a non-teratogenic substance to the pregnant woman? Did you mean it's safe for the pregnant woman to smoking or something?
What? I'm so sorry.
Which slides? Yeah, our Mr. Donald just want to make sure about the nicotine use in a pregnancy. Is it safe to use in pregnancy, or I think it doesn't mean that nicotine come from the cigarettes. Yeah.
Yeah.
Or maybe you can explain more detail about the nicotine
This is non-teratogenic. Non-teratogenic, Pak.
Yes.
This is a non-teratogenic for apa tadi, Pak?
Also, so it's very harmful for the fetus or the mother.
I think so.
What can you explain more about what is the meaning of non-teratogenic actually?
Yes, nicotine is generally non-teratogenic, but is still harmfully in pregnancy because it reduces blood flow to the placenta and increase risk such low birth weight, birth, preterm birth, and pregnancy complication.
Okay, so even this substance is non-teratogenic, but it's harmful for the fetus and the mother, right? Okay, I think Miss Tuti, that's
Yes.
it. Yeah, that's the problem.
This is your problem, and it's not one of your evidence to smoke in front of the pregnant woman, Mr. Dona.
Yeah, hopefully there's no more pregnant woman in my house.
Yes.
Yeah,
Maybe in public, maybe
enough, I
in the
think.
public, in your environment. Okay. Maybe the Miss Verena said that nicotine in some dose non-teratogenic, they give non-teratogenic effect. It doesn't mean they can safe to use as a medicine. Maybe it looks like if the woman have or in the environment, maybe they can or they what can I say? Not for the woman, maybe the Miss Verena, yes, for the people around the woman give the nicotine effect. This is okay. There's non teratogenic because maybe the small dose or non I mean not directly for give something like that. Itu nggak Mbak Verina? Jadi mungkin kalau maksudnya takutnya nih kan juga ada ya suka pertanyaan ibu hamil gitu kan deket-deket sama yang ngerokok nggak boleh gitu kan. Sebenarnya kalau deket doang mungkin sedikit doang kan yang nggak langsung menyebabkan kecacatan gitu ya. Cuma memang tidak baik begitu nggak sih Mbak maksudnya? Kadang-kadang kan
Berarti
bukan
satu
dari
batang
ibunya
boleh
ya.
ya?
Dari orang-orang ya kan gitu kan ada yang ngerokok gitu kan ya kehirup sedikit demi sedikit nggak apa-apa lah gitu nggak maksudnya Mbak Verina. Saya juga jadi penasaran nih Pak Dona nanya ini. Mungkin Mbak Verina bisa memberikan pencerahan gitu Mbak Verina.
Iya sih, jadi sebenarnya memang berbahaya. Cuma dia memang untuk membuat orang yang tadi apa namanya membuat dia akan menjadi lebih cepat apa sih preterm labor tadi dia akan apa istilahnya ya apa sih preterm labor? Jadi dia prematur birth, ya. Yes, this premature birth.
Tapi kalau dosisnya sedikit gitu tadi kayak di lingkungannya pada merokok itu masih aman lah ya. Atau satu batang sehari boleh?
Mohon maaf Bapak, nanti coba saya mencoba untuk mencarikan referensinya terlebih dahulu untuk berapa dosnya atau berapa banyak untuk sampai bisa menyebabkan hal tersebut.
Oke, terima kasih Bu Fe, terima kasih Bu Tuti.
Okay, Mr. Dona, I think this is one of the most issue, the most important issue in Indonesia. This is why our government give us announcement to do not smoke in the public area. This is one of the implication, because the nicotine is non teratogenic, but it's not good for the health, even though it's not a pregnant woman, but all the people, something like that. Maybe satu ini Pak ya, satu batang sehari itu jauh-jauh, tapi Bapak ngerokoknya jauh gitu ya Bu Farina ya, mungkin di sawah atau di mana. Tidak dalam radius banyak orang. Biasanya kan sekarang juga ada sudah special space for the people who want to cigarettes or want to smoke. Okay, Miss Verena, thank you so much for your attention, for your attending here, and for your sharing about the drugs in pregnancy. I think a lot of the question that we cannot accumulate in this conference, maybe all of the participants, you can contact us directly to Ms. Verena if you want to discuss or if you want to have some interest of the research. But before that, Ms. Verena, I will give you the certificate from our committee. The certificate of the appreciation is probably presented to Ms. Verena Damayanti. Thank you so much, and we will give or send it by email. Okay, before that, Ms. Verena, maybe you can smile. We will take a picture together for the certificate. Okay, 1, 2, 3, smile. Okay, thank you so much, Ms. Verena, for sharing with us today. Thank you, and I hope so we will continue. Ya, ini Bu Miss Inayah juga ada, Bu Nur Inayah ada pertanyaan. Dan juga tanggapan ya Bu ya. We have a feedback from our participant about this discussion about the nicotine for pregnant women. Thank you. Oh, this is the feedback from me, Dr. Fajrila. Thank you so much for the feedback. And of course, we are a health professional is committed to give the healthy environment for the pregnant woman. So we cannot have, or we try our best to make a pregnant woman free from nicotine. Especially when the people smoke around the public service in Indonesia, they not allow for smoking in front of or maybe near to the pregnant woman. Thank you so much. Okay, ladies and gentlemen, we will continue to the next our international speaker, our distinguished international speaker, Mr. Mustafa. I can see in Zoom. Good morning, Dr. Mustafa Saban.
Good morning, sir. How are you?
I'm very well, very fine. I'm very happy and also very healthy
Me
today.
also am happy to share you.
Okay, thank you so much, Mr. Mustafa, for attending here today. I think now in your country is still morning, right? Early morning.
Yes, it's early morning.
Early morning. Okay, Dr. Mustafa, maybe you can prepare first, and I will read your short CV before you start your presentation. Okay, ladies and gentlemen, this is the short CV from Dr. Mustafa Shaban, Doctor of Philosophy. He is an assistant professor in geriatric and community health nursing. This is his contact in email or the address. If you have some interest for the research with Dr. Mustafa Shaban, maybe you can have a discussion. Dr. Mustafa Shaban is a student-centered nursing academic with strength in community and geriatric nursing. Okay, he is Master of Nursing program and served on quality e-learning and statistics committee at Jove University. He also got a scholarship spans nursing education innovation, AI technique ethic and adoption in nursing and gerontology care. Dr. Mustafa Shaban bring a balanced profile for teaching. And this is, you can see the research interest in geriatric nursing, nursing education, AI, family engagement, palliative care, and critical care communication, climate or eco-conscious nursing and planetary health. This is the academic appointment now in Cairo University, Egypt. And before that, he also lecturer in Cairo University. This okay, I can read one by one, but you can see he is very active as an editorial and a peer review. Have a lot of the research in international reputable journal in Scopus or World of Science. You can see the publication since no, I think a lot of the publication every years. He very active to research. There is a lot of the training certification and also a workshop in international conference and international workshop. He have a skill in teaching and curriculum in the research and also in the big data, I think. And he can speak Arabic and also English. Okay, it's very interesting for me, Dr. Syaban,
Thank you,
to
Doctor.
have you here. I can
Thank
see
you.
one of our interesting in AI and big data. So I want to learn more about this from you today and all of the participants. Please
You're
welcome
welcome.
Dr. Mustafa Syaban. To Dr.
Thank you.
Mustafa Syaban, the time is yours.
Okay. I am trying to share, but there is something issue.
Okay, maybe you want to the committee for sharing your PowerPoint presentation, maybe Dr. Mustafa?
Yeah, I'm trying.
You need assistance?
Yes, please.
Okay, Mr. Dona, maybe you can assist Dr. Mustafa for sharing the material, or I will try.
Okay, please wait. I will find one.
I think it shows now.
Yes, can see now.
Okay.
Yes, Dr.
Good morning,
Mustafa,
everyone.
it's clear to me too. Okay.
Good morning, everyone.
Morning.
Today we have to show our presentation about our published article. It is a qualitative article. It is titled was I am still young woman. Women lived experiences of precocious or pre-menopause. It is a qualitative studies among Egyptian women. The author Osman El-Kist, El-Anizi, and Mustafa Shaban. As we know, menopause it means that permanent cessation of menstruation typically occurs on 45 to 54 years. As precocious or premature menopause, it is meaning the onset of cessation of menstruation before the age of 40. It can be due to many causes, often due to premature ovarian insufficiency or surgery, chemotherapy, or sometimes idiopathic causes. It can be associated with many signs, such as vasomotor symptoms, such as hot flashes, night sweats. It can lead to sleep disturbance, fatigue, joint pain. Also, it can be associated with long-term risks such as cardiovascular disease, osteoporosis, infertility. This early loss of infertility can affect a woman in many aspects of her life, such as poor self-image, femininity, and identity. It's cause also material relationship conflict and family role conflict. Also, its effect emotional well-being leads to anxiety, depression, or some grief. In our Middle Eastern context, womanhood is closely tied to motherhood. Women see his identity as being a mother. So, losing infertility and early menopause may be stigmatized for this woman. Also, they fear of divorce as a consequences of the early menopause. It's also lead to blame and misunderstanding from family or her community. Our research aim or overall aim was to explore the lived experience of Egyptian women with precocious or premature menopause. Our key questions was how do women describe physical and emotional impact of early menopause? How do family, culture, and social expectation influences their experiences? What coping strategies do women use to manage this transition? And the last question was how do women perceive their interaction with healthcare provider, particularly nurses? So, to achieve the aim of our study, we adopted qualitative descriptive study. This qualitative study was guided by naturalistic perspective, which aiming to explore phenomena in real life context. Also, we adopted social constructivist lens, which experiences constructed through culture, family, and health interaction. This was guided by standard for reporting qualitative research, which focusing on rich, contextualized description rather than testing specific theory. So, our study was conducted in reproductive health clinics and community centers in Egypt, especially in Nile Delta region. Our participants were 15 women diagnosed with precocious or premature menopause. Their age ranged approximately from late 20s to late 30s. There was valid marital status, such as married, divorced, or widowed, and different parity. There was different educational and employment background. All 15 women was diagnosed and confirmed by physician period recruitment. So our sampling strategy was purposive sampling as is a rare phenomena. So we adopted this strategy. Women who could articulate their experience and consent to participate. There is not many women diagnosed with precocious menopause, so we adopted purpose of sample. Our inclusion criteria was premature menopause before the age of 40, Arabic speaking, able and willing to share experiences. Our ISCAL approval was obtained from Institutional Review Board of Faculty of Nursing, Tanta University. All the participants have a written informed consent with voluntary and confidentiality and right to withdraw emphasized. For the data collection, we used in-depth semi-structured face-to-face interview in Arabic, which was later translated in English. Our interview guide covered different aspects or different points, such as diagnosis journey and initial reactions, physical and emotional symptoms, impact on identity, marriage and family life, support system and coping strategies, experiences with nurse and other provider. Each interview duration was 45 to 60 minutes. Some follow-up interview for clarification. Sometimes if something is missing or some code is not available. Additional data as a researcher take field note to capture non-verbal cues and context where the words can't be described. For the analysis, we adopted semantic analysis developed by Brown and Clark 6 steps, which include familiarization with transcripts, initial coding, searching for themes, reviewing and find themes, and finally produce rich narrative account. All verbatim transcription of the interview was in Arabic, then translated by official translator into English. For our results, the participants were 15 women, and this number was achieved as saturation achieved when no new data was captured. The age mostly late 20s to late 30s. Age at diagnosis often several years younger than current age of the 40. In marital status, majority married. Some was divorced and widowed. Some with no children. Other with one or more children but still desiring future fertility. And this was the big problem here. So, for the themes, we generated 3 themes, main themes with subsequent themes. Themes 1 was physical and emotional shock of early menopause. Many women have a sudden or unexpected diagnosis. Many women describe shock, disbelief, and denial as all of them saying one word, I am still quite young. Also, they express distressing symptoms such as hot flashes, excessive sweating, palpitation, fatigue, joint and back pain, also sleep disturbances. For the second theme is losing femininity and identity disruption. Menstruation and fertility seen as the core to femininity and womanhood. Loss of menstruation equal feeling of less woman or defective woman. Concern about attractiveness and desirability to husband was their main big problem. For the third theme is family, marriage, and cultural expectation. Strong cultural expectation to marry and bear children quickly. For here in Egyptian community, they expect from girl when it is married, it is early bearing and early pregnancy. So if lost their menstruation, this is lead to loss of her identity. Also, there was fear of marital instability, worry about divorce or husband taking another wife. Also, they express the reactions from spouse, some supportive and understanding, other distant, blaming or pressing for fertility situations. So, our study have different implications, such as integrating premature menopause into nursing curricula, training the nurse in culture-sensitive communication about fertility loss and identity threats, developed nurse-led support program and counseling service for younger women. As this, we also have some limitation. As small sample size, which come from purpose of sample from a specific clinic, it may be limited generalizability of the data. Second, only human perspective, no data from spouse or healthcare provider. Also, cross-sectional design experiences may change over time. So, In conclusion, precocious or premature menopause profoundly affect young women's bodies, emotion, identities, and relationship. Cultural norms that prioritize fertility and motherhood intensify the burden and stigma. Women draw on fires, family, peer, and self-advocacy to cope and rebirth their life. Thank you for your hearing, and I am very happy to be with you today. Thank you, everyone, and I am ready for any question.
Okay, thank you, Dr. Mustafa, for sharing your research about the precaution menopause. It's really interesting, and in Indonesia, not it is still a limitation research about the precaution menopause, especially in the qualitative design, because it's really hard to do the qualitative design, for example. Okay, ladies and gentlemen, you can ask the question directly by raise your hand, and it's no problem if you want to ask with Indonesia or with Bahasa. I will try my best to explain in English, or you can write your question in chat Zoom. Okay, Dr. Mustafa, we have one question come from Ms. Sunik Cahyawati. The question is, can you explain about early lost fertility can cause the precaution or premature menopause in Egyptian women? Okay, I think this is you mentioned before in your PowerPoint, right? I think in the slide 2 or 3. Okay, Dr. Mustafa?
Okay, sorry, the mic was closed.
Yes.
The losing of fertility is a sequence of precocious menopause. It is losing of being menopause before the age of 40 may lead to loss of fertility. And this was expected from the Egyptian woman to be fertile until the age of 40. And this is cause a burden of the woman. Can lead to psychological or emotional burden and cause marital conflicts here in Egypt. So we focus on this problem to try to get the lens on this problem to expect new solutions for this and adaptation from the woman with these serious problems.
Okay, maybe Ms. Sunik, you can give the response. Maybe is this clear or no? Yeah. So the focus of this research about the what we can add this the after they have a precaution and what they feeling and or what they feel in their body, something like that. This is the focus of this study. Okay, the next
Thank
question.
you.
Thank you, Ms. Unik. Okay, Dr. Mustafa, one of the question come from the personal chat for me. They're asking about the limitation. What is the limitation of your research and how can we develop or maybe what suggestion for the next researcher?
Okay. For all qualitative studies, the limitation typically the limited number. And in most qualitative studies not depend on the large number because of the narrative nature of the data. We can't handle big narrative data. So we depend on something called saturation. So to overcome this limitation, we reconduct our research or our experiment in different context and different culture to cross align this result with different population and different culture to overcome this limited number. What is the big main limitation of our study is the small number of participants. Also, the fear of participation from the women it can hinder our collection of data. As you know, the Egyptian woman may be hesitated to participate in this special private data. They see as private data and can't express their feelings so easy. To handle this, we have a co-researcher, female co-researcher, who have the interview with them to gain trust. No male was participating in the interview because of the privacy and a feminine issue. We can handling this by providing private room, expressing the privacy for the woman to express and talk in free. Okay, thank you.
Okay, thank you, Dr. Mustafa, for your answer. I think yes, the most limitation in qualitative is about how we can collect the data or something like this. I have a question just come from myself about this topic. It's because it's really interesting. I just want to know why you do this research, because you are a man also, and you say that before. One of the limitation, there is no man in the subject, but you are a man. So why you have the interesting in precaution menopause or something like in Egypt, there's no policy for this, or there is no maybe there is no intention for this. This is why you do this research, or maybe you have some maybe explanation. So why you try to do this?
Okay.
It's very interesting for me because you're a man, something like this.
Yes. Okay. As early menopause, it is lead to later unhealthy aging. As you know, my specialty is geriatric. So we focus on healthy aging and aging transition. To achieve healthy aging, it is have many advanced circumstances that should be happen before we reach age 60. As a menopause happen in the age 50, it is a main event pre reaching elderly stage. So to have a healthy aging, you have to build an advanced status of well-being. For women and men, they have a different circumstances. Also, women have being geriatric. So it is no matter man or woman dealing with geriatric, we focus on advanced status that lead to healthy aging. We need to build a program, a wide program in the healthy aging in Egypt, and we focus in this. We has a mini aspect in man and woman health. So to deal with elderly women, we searched the common problem they face in the pre-aging stage, and we found this can be a leading cause of losing of well-being. So we cooperated with gynecological researcher with us to search in this problem. The main issue here, I'm really a man, but we have a co-researcher in gynecological nursing.
Okay, thank you so much, Dr. Mustafa, for your explanation. This is why I think in Indonesia is still a limit researcher in geriatric, and especially the gender is male. A lot of the female researcher focus on the geriatric, and Indonesia we call the one of the policy from our government is Prolanis. Prolanis is one of the specific policy for geriatric for the elderly, but it's still limitation of the male research, and I think it's really interesting. Maybe you can it's already published, right?
Yeah, it is published in PMC Nursing.
Okay, in PMC Nursing, so we can learn more. All the participants, this is already published. this research, so you can see and you can learn more about this research. Okay, Dr. Mustafa, thank you so much for attending today
Thank you.
in
Thank
our
you.
conference. It's really interesting, and I hope that we can invite you again in the next conference with the inspiring
Thank you,
and
Timur.
very interesting topic. Okay, as
Thank you.
a committee, I will send the certificate of the appreciation for you, and we will send it by email. Or maybe if you able to open your camera, if you able to open your camera, Dr.
Okay, it is
Mustafa.
not working. It is not
Oh, it's not working.
Okay.
Okay, thank you
Good.
so much, Dr.
Thank
Mustafa
you.
Saban, for
Thank you.
attending. I hope you can
Thank you.
continue the day because it's still in the morning in your
Yeah,
country.
yeah. Good day for you.
Okay, assalamualaikum, Dr. Mustafa.
Assalamualaikum. Bye bye.
Okay, ladies and gentlemen, it's a really interesting topic from Dr. Mustafa, and we will continue to the next international speaker, our honorable international speaker, Dr. Reda. I can see Dr. Reda in Zoom. Good morning, Dr. Reda.
Good morning. How are you?
I'm fine, Dr. Reda, and I'm really happy to can interact with you again because we still have a meeting in Zoom. We don't have any time for meeting in fact, or maybe I can easy come to your country or you not come to my country, but I'm really happy to see you and also to have a discussion again to you. Okay, Dr. Reda, before you start your presentation, let me introduce a little bit about yourself to our participant because we have a new collaboration again with Amamuju. So there's a lot of the new participant here. So I can introduce Dr. Reda. Dr. Reda, is this not the first time we have a collaboration with Dr. Reda for International Conference on Nursing and Health Sciences? Dr. Reda Mohamed Nabil Abdushadi. She is a lecturer, also assistant professor at maternal and newborn health nursing at King Saud Health Science. Before that, she is also professor at maternal and newborn health nursing in Faculty of Nursing, Cairo University, Egypt. This is the personal email. So if you want to have some interest for research, you can contact in person to Dr. Reda. This is the Scopus ID, and also Dr. Reda is editorial board and a membership of Journal of British Microbiological Research, and she is also a reviewer in a national and international journal, more than one, and also active for attending a national and international conference, something like this. She also supervised on several theses and also dissertation and published. We cannot write one by one. You can check in the internet because a lot of the paper that she have been published in high index international journal. Okay, ladies and gentlemen, I think we start for learn with Dr. Reda Abdushadi. To Dr. Reda
Thank
Abdushadi,
you.
time is yours.
Can you give me request for share?
Yes, and now you are a co-host. Maybe you can try, Dr. Reda.
Okay, wait.
Or share screen. But if you have some problem, the committee will help you.
Try to share, but I didn't find desktop.
Oh, yes. No, Dr. Reda, you want to the
From screen?
for helping?
Yes, here.
Oh,
It's
no,
appear.
yeah, in process. Okay, now I can see your PowerPoint presentation, but it's not full screen. Maybe you can try it full screen, Dr. Reda.
It's good now.
Still not full screen in my laptop. Okay, now it's a full screen, Dr. Reda, and I can see clearly.
Okay. First of all, good morning for everyone. Thank you for giving me this chance to attend this conference. Also, I would like to extend my sincerely thanks to my colleague, Dr. Amal Dawood, for her kind invitations to attend this conference. And I appreciate Dr. Mustafa Shaban here, his international publications and a good presentations for article regarding menopause women. Thank you, Dr. Mustafa. Now my article or my speak notes about the challenge facing my midwifery nursing. This is my specialty, midwifery nursing, and I have a license also from Ministry of Health in Egypt for delivery. My outlines, introductions, challenge facing midwifery nursing, strategy to overcome this challenge. Did you hear me?
Yes, doctor, I can hear your voice and I can see your PowerPoint. Perfect.
Okay. Midwifery nursing is a cornerstone of maternal and neonatal health care, providing holistic, patient-centered care that supports women and family through pregnancy, childbirth, and postpartum period. Globally, midwives are recognized as a critical healthcare providers, contributing to decreasing maternal and infant mortality rates, as evidenced by World Health Organization 2022. Reports emphasizing their role in achieving the Sustainable Development Goal related to the health, Goal 3, of reducing the maternal mortality ratio to be less than 70 per 100,000 live per birth 2030. Midwifery nursing integrate clinical expert, emotional support, and cultural sensitivity, addressing diverse needs across various health care settings, from hospital to community-based health centers. Review of literature highlights the unique contributions of midwives, such as lower rate of cesarean sections and the higher patient satisfaction compared to physician-led care in low-risk pregnancy. Despite its proved benefits, midwifery nursing faced challenges, including limited recognitions in some healthcare systems, inconsistent regulatory framework, workforce shortage, lack of autonomy to practice to their full scope. The goal shortage of midwifery, estimated by WHO in 2022 to be 900,000 under mean effort to provide equitable maternal care, particularly in low and middle income countries, including Egypt. Additionally, burnout and inadequate training opportunity hinder the retention and professional development. We have two questions. Question one, what is the challenge preventing midwifery from achieving a full professional recognitions and the scope of practice? Our challenge, medical dominance and hierarchical health system, lack of legal and regulatory support, gender bias and professional under-evaluations, insufficient training and education opportunity, workplace discrimination and poor working conditions, policy and funding gap, public misunderstanding and low visibility. Regarding medical dominance and hierarchical health system, midwifery is often overshadowed by medical model of care, particularly obstetricians. Physicians, especially obstetricians, may resist expanding midwifery role due to perceived threats to their authority or income. Lack of legal and regulatory support. Midwives lack a clear legal framework defining their role, scope, and autonomy. License or credentialing system may be absent or weak or inconsistently enforced. Midwives may not be allowed to prescribe medications, perform essential procedure, or lead care even when trained to do so. Regarding gender bias, midwifery is female-dominant professions, and like many such fields, it is often undervalued and underpaid. Persistent gender inequality within health system can diminish the professional status of midwives. The role is sometimes seen as less scientific or skilled compared to that doctor or nurse. Regarding insufficient training, inconsistent or inadequate education standard for midwifery in some countries affect the profession's credibility. Lack of investment in midwifery educations limit opportunity for professional development, leadership, and specialization. Workplace discrimination and poor working conditions. Midwives often face disrespect, marginalizations, or exclusions from decision-making in clinical setting. In some contexts, they work in under-resourced, high-stressed environment without sufficient support, supervision, or equipment. Regarding policy and funding gap, national health policy may fail to regulate or integrate midwifery into maternal health strategies, limit funding for midwifery-led service and birth centers, restricted access and innovations. Poor representations in policymaking bodies prevent midwifery from advocating for their professions. The public and even some health professionals may have a limited understanding of what midwives do and the value of midwifery-led care. This led to underutilization of their service and continued reliance on hospital-based physician-led care, even in low-risk pregnancy. For the second question, how can the healthcare policy, including the Ministry of Health and Populations, better integrate midwifery, nursing to optimize maternal and neonatal outcome? Integrity midwifery, nursing in the healthcare system more effectively is crucial for improving maternal and neonatal outcome. To achieve this, the Ministry of Health and Populations and Border Health Care Policy must take a comprehensive, multi-level approach that strengthens the rule, educations, and regulations, and the leadership of midwifery professions. Through policy and government, develop national midwifery policy strategy that align with WHO and international confederations of midwifery standards. Include midwifery in policy-making bodies, especially in reproductive, maternal, newborn, and child health programs. Strengthen leadership role for midwifery within the Ministry of Health to influence planning and resource allocations. Recognizing midwifery as stand-alone professions, not just subset of nursing. Regarding education and training, develop or extend direct entry midwifery education program that meet global standards. Strengthen clinical training through well-equipped teaching hospitals and simulation centers. Support faculty development, including training of trainees for midwifery educators. Establish licensing exam and continuity education specifically to midwifery. Workplace planning and development. Conduct human resources for health mapping to identify shortage and gap in midwifery coverage. Develop midwifery strategies, especially in rural, remote, and undeserved areas with high maternal mortality. Develop intentions such as housing, career development, hardship allowance, and supportive supervisions. Integrated midwifery into primary health care team, maternity unit, and the community-based care model. Regulations and accreditations. Establish or strength of midwifery council or similar regulatory body for license and professional standards. Ensure all midwifery education programs are accredited and regularly reviewed. Mandate registrations and license renewal with continuity professional development requirements. Regarding service delivery integrations, standard midwifery-led care models in maternity service, antenatal, intrapartum, postpartum, and newborn care. Expand the midwife-led birthing center, integrate them into referral system. Enable midwives to prescribe essential medications, manage complications, and perform emergency procedure within their scope. Promote respectful maternity care and reduce unnecessary intervention, for example, cesarean section through midwifery models. Data monitoring and evaluations include midwifery-specific indicator in health management information system, monitor maternal and neonatal outcome in facility with midwifery care versus without, conduct operational research on the impact of midwifery on health outcome, use data to inform planning, budget, and advocacy. Community engagement and awareness, implement public awareness campaign on the role and benefit of midwives, strengthen community-based educations on birth preparedness and danger signs, involve community leaders and women's group in advocating for midwifery service. For financial and sustainability, allocate detected budget lines, midwifery educations, recruitment, and service. Engage donors and partners to support midwifery scale-up, include midwifery service in university health coverage package. What is the strategy to overcome this challenge? For education, competency-based and interprofessional learning, integration technology and simulations, global health culture humility, lifelong learning and specializations, leadership and advocacy training. We have here interdisciplinary educations. We have learning management example for education and continuity, using a learning management system, hybrid learning, blended learning, using for educations a virtual classroom, flipped classroom, just with strategies, gamifications in educations, mind map, high fidelity simulations, virtual reality like lab. For research, person-centered and implementation science, technology innovations and research, collaborate and interdisciplinary research, equity-focused research, knowledge transition and disseminations. Technology innovations, collaborations, equity-focused, knowledge transitions. Last one, midwifery, nursing, and make overcome this challenge through practice. Using automized and collaboration practice, technology augmented care, holistic and wellness-oriented approach, community-based and culture response care, advocacy for policy and system. For autonomous, midwives will practice as autonomous healthcare providers with an interprofessional team, collaborating seamless with the obstetricians, pediatricians, primary care providers, and other specialists to ensure comprehensive and integrated care. Technology, using the technology, like as you see in our slide, visual reality in maternal delivery, Nova wireless patch system, future of fetal monitoring, telenursing, robotics in nursing. Also using electronic medical records, handheld ultrasound for maternal and fetal health, using baby movement mobile applications to monitoring the baby, and using calibrated obstetrician strip to calculate the amount of blood after the delivery. Holistic and wellness-oriented approach, practice will extend beyond the traditional health care model, encompasses preconceptions, counseling, sexual and reproductive health, adolescent health, menopause care, and mental health support, with a strong emphasis on health promotions and disease prevention. Community-based culture response care, midwives will increasingly provide care in a diverse setting, including home, community clinicians, and rural area, adapting care models to be culturally responsible and address the specific need for local populations. Advocacy for policy and system change, midwives will actively advocate for policy that support the full scope of midwifery practice, ensure equitable access to care, and strengthen health system. Two priorities, maternal and neonatal and newborn health. This includes advocating for fair remunerations, safe working conditions, and professional recognitions. In conclusions, midwifery nursing face multiple challenges in education, practice, and research, including limited resource, high workload, lack of training, and difficulty in translating research into practice. However, this challenge can be addressed through updating curricula, improving the work environment, providing emotional support, fostering a research cultures, and ensuring continuous funding and training. My reference. Thank you. Thank you for attention. Thank you for listening. Thank you.
Thank you so much, Dr. Reda, for your sharing. It's really a lot of the information, and also when I read your PowerPoint presentation, I found a lot of the inspiration about the
Thank you.
topic. Yes, some of the cases and some of the problem is happening in Indonesia. I make find in like public misunderstanding. Is Indonesia is
Mm.
there are a lot of public misunderstanding. Sometimes it can be a national issue. Misunderstanding in one public health service, they post into medias in social media, and then can be a national.
Yes.
It's really happened in
This
Egypt.
our yes happened in
Really?
Egypt, and we have misunderstanding. The media is not focused for the role of the midwives. We haven't policy or regulations to support midwife to take this role. So we have counseling and Egyptian counseling now try to make charter to make us like policy to but it's in process. Until now, physicians facing this process,
Oh, yes, yes. I think
especially male physicians.
yes, I think our government must do the same thing, because when the public misunderstanding come into the public issue in the social media is too wild, to the gossip in every aspect come out. I think our government cannot handle or cannot give the focus of the health professional to give their physician to or to explain the policy, to
Yes.
explain the focus of this happening, something like this. I think in Indonesia
In
we will.
Saudi Arabian, here we have this rule. Saudi Arabian, we have courses and program for midwives, and we have a lot of hospital focusing in midwives first. The mother coming for antenatal, the first booking with midwives. Also in delivery room. Yes, in delivery room we have first midwives, and sometimes the mother told the midwives, "I need physicians." She told her, "No, this is my rule until arise any complication. The physician will be with me."
Okay, it's really interesting, and I think
So
we
when
must
yes,
yes, so powerful and a health professional. We needed this. Okay, ladies and gentlemen,
yes,
I will give you the opportunity for discussion to Dr. Reda. You can explain in Bahasa, or you can raise your hand and write in the chat. Okay, Dr. Reda, we have one question from our chat Zoom. Okay, it's about the public misunderstanding. I think what should be done to overcome various challenges in maternal and child health services, especially in public misunderstanding. Maybe Dr. Reda has explained when
yes.
I have a discussion, but maybe if you want to explain another or maybe more specific, Dr. Reda is okay.
The first thing it is mass media. We need to arise awareness regarding the role of midwives through mass media. The mass media is, or social media, it is the basic, the one from challenge can be overcome. أو improve the misconception regarding midwives in nursing through mass media. And
Okay.
increasing continuity educations and the practice. And the nurse must be up to date for research, educations, and the practice.
Okay, maybe Miss Sunik, you can have the response, maybe okay or something. You can chat again in chat Zoom, or maybe you can open your camera and say hello to Dr. Reda. Yeah, Dr. Reda, this is one question again that happened. Oh yeah, Miss Sunik.
Okay, thank you.
Okay.
Thank you.
Okay, Dr. Eda, one question come from our committee's chat, but it's really shy to ask directly to you. It's talking about the holistic learning that you has announced in your PowerPoint. Has holistic learning has been implemented in your country, and who are the professionals that can involve to give the holistic learning?
Holistic learning already found in our country in Egypt and start after COVID-19. We have online learning, we have can using flipped learning during the method of teaching. The method of teaching already changed after COVID-19 for using modern or innovative method of teaching. So the already we have a program, but we haven't policy makers. We need involved policy maker with us to improve and to give us the policy to working. We have a lot of programs for midwifery in Egypt and using a holistic educations.
Okay, thank you for your answering. Maybe I can give the feedback to our committee where I will send it. The holistic medicine, including the education for the preventive, rehabilitative, and also or just for curative?
For all, from the preventive, curative, and rehabilitations.
Okay, I think all of the question is been answered with very clearly, and maybe a lot of, I think when I see your PowerPoint,
This is
seems
my main
different
issue.
with
Yes,
a lot
I
of
think
the
this is my main
insight.
issue.
A
We
lot of
need
insight.
a decrease. Yes, we need to decrease the maternal mortality and morbidity. This will be achieved through midwifery nursing and the role of midwifery nursing to be a rise. Also, the cesarean section rate is being increased in Egypt and a lot of countries. So one of to decrease this cesarean sections, the rule of midwife to be up to date, and we
Yes.
have a policy to using this role.
Yes, I really agree with you, and also the education and also the sharing like this is very important to make sure that we have some problem, but not all the problem we have the same solution. Sometimes we don't have a solution, you have a solution, or maybe we can share the different solution to make it complete, something like that. Professor Dr. Reda. Okay, Dr. Reda, thank you so much again for coming. I think now in your country still morning, right?
Thank you. Thank you. Have a good day.
Have a good day. Okay, Dr. Reda, maybe you can open. Oh, maybe you can flip it because yes, maybe you can flip your camera because
Camera?
yes, your camera can be open because your head. No, I mean you can flip. Yes, because your head is up now. You can maybe rotate the camera because I can see your,
Okay.
but it look like you are. Yes, I think you are hang out in.
Yes, I'm trying to rotate my camera.
Yes, you can rotate it and we can take a picture after that.
So I think, yes, I think this, I have problem for this camera.
Oh, yeah, because maybe if I take the picture, you are hang out, so is not good enough for taking a picture. Maybe yes. This is the certificate of appreciation for Professor Reda and Nabil
Thank
Abdush.
you. Thank you. Thank you. Thank you.
Okay, Dr. Reda, we will send it to you by email. I hope you enjoy your day because it's still morning, maybe in your country. And Assalamualaikum warahmatullahi wabarakatuh.
وعليكم السلام ورحمة الله وبركاته. Thank you.
Thank you, Dr. Reda, and a lot of insight and inspiration that come from our international speaker that we have formed since the first international speaker until now. I think a lot of the information, the new perspective that we can accept or that we can learn or that we can explore again, or maybe we can have a collaboration. It's still possible for do that. Yeah, so tadi ya, dari mulai pemateri yang pertama ya, baik nasional ataupun internasional speaker, kita sudah banyak sekali mendapatkan insight, mendapatkan banyak sekali masukan dan juga mungkin ide-ide ya, ide-ide yang bisa kita explore lebih dalam, yang juga bisa kita diskusikan, atau mungkin bisa kita kembangkan dalam kerjasama ya, seperti tadi banyak sekali masukan-masukan dan mungkin banyak masalah yang sama yang terjadi antara Indonesia dan juga negara-negara lain. Okay, ladies and gentlemen, we will continue to the next our international speaker today, and I can see her in Zoom, Dr. Amel. Good morning, Dr. Amel.
Good morning.
Good morning. Thank you so much, Dr. Amel, for coming again in the ACNHS.
Thank you. Thank you very much. Thank you. It's my pleasure to join with you. My second home. Thank
Yes.
you. Congratulations for successful your international conference as usual.
Thank you so much, Dr. Amel. Okay, Dr. Amel is
Yeah.
ready to give the material, but before Dr. Amel give the material,
I
let
can
me,
share on my side.
yes, I will
Yeah.
introduce you to all of the new participant because we have a new collaboration again with Mamuju and a lot of the district in Indonesia. Before you start your presentation, I will read your short curriculum vitae to make sure all of the participant maybe know more a little bit about you, and I will read it in bahasa maybe. Ya, teman-teman, Dr. Amel ini pemateri yang sudah bergabung bersama kami, bukan pertama kali, ini sudah kali kesekian ya beliau bersama kita. Dr. Amel Daud Kamel Gauda, atau bisa kita panggil Dr. Amel Gauda. Ya, dia merupakan seorang profesional kesehatan di bidang maternal dan juga newborn atau kesehatan ibu dan anak ya, bidang keperawatan. Dengan posisi sekarang adalah beliau sekarang ada di mengajar di Mesir dan juga Saudi Arabia. Dr. Gauda adalah Associate Professor di Maternal and Newborn Health Nursing Service di Cairo University di Mesir dan juga mengajar sebagai asisten profesor di Saudi. Dan tentunya beliau adalah koordinator dari Master Program Midwifery di Mesir. Dan juga kontribusi beliau di sini banyak sekali dalam mengajar, tentunya dalam meneliti, baik mahasiswa master maupun mahasiswa doktoral di Mesir dan juga di Saudi. Her expertise atau keahlian beliau secara internasional tentunya sudah tidak perlu kita ragukan lagi. Beliau adalah editorial board dan juga reviewer di beberapa jurnal internasional bereputasi. Ya, di sini bisa kita lihat di antaranya ada beberapa jurnal yang memang high reputable dan juga beliau aktif dalam memberikan training dan juga memberikan materi pada konferensi nasional dan juga internasional, terutama pada training-training di daerah Timur Tengah, ya, Middle East and beyond. Jadi Timur Tengah dan juga daerah lainnya. Oke, kita akan belajar new perspektif ya, perspektif berikutnya dari Dr. Amel. Okay, Dr. Amel, we want to learn a new perspective from you and the new information. I'm really excited what the new information, what is the new inspired.
Thank you for your introduction. Thank you for great introduction.
Okay, for Dr. Amel Daud Kamel Gauda, the time is yours.
You can open share. I can share from my side.
Yes, you are a co-host. Maybe now.
Yeah.
You can try. Maybe the committee. Can you make Dr. Amel as a co-host? Pak, ini Pak Dona boleh dijadikan co-host Dr. Amelnya agar beliau bisa share screen. Oh, wait a minute, Dr. Amel. Yes, you are a
Yes.
co-host now. Maybe you can try to share your PowerPoint. Yes.
You see my screen?
Yes, has started, Dr. Amel, on process. In my screen is still on process. Yes, I can see your PowerPoint clearly, Dr. Amel, so you can start your presentation.
Yes, today I will talk about technology, future technology in nursing education and nursing practice. Tell me and I forget, teach me and I remember, involve me and I learn. The first description of innovation by Benjamin in early 19th century by Amal Gouda. Technology will overwhelming the impact on nursing profession as evolved hospital continue to be overrun by high volume of patients they see daily by using latest advancements. The nurse on the front line will be able to serve their patient more effectively and efficiently. Technology advance continues to transform the medical landscape, but has both benefit and challenge. Emerging technology include electronic record keeping and providing patients with more access to their data. Still, some hospitals will have deal with those who are not open adapting new technology. Civilization owes its existence to change. Teaching for change, change teaching. This is the hierarchy Bloom taxonomy, starting from the base of remember and recall and up to analysis, initiating, practicing, and adapting. Sixth stage, cognitive domain, processing information, constructing, understand, applying knowledge, solving problem. Effective domain, receiving, response, valuing, organization. Psychomotor domain, observing, initiating, practicing, and adapting. Generalization Z. Now, all of us contact with generalization Z. Generalization Z born from 1996 until 1910. I hear and I forget, I see and I remember, I do and I understand. This characteristic of generalization Z, copy and paste, ChatGPT, Gemini. And after 2010, generalization alpha and more using for technology and ChatGPT and other type of technology. Innovative creative teaching is must be used with generalization Z and alpha and after that beta generalization. Innovation is act of constructing, thinking, grouping knowledge, skills, attitude into new original, rational idea, interactive learning process, critical thinking, plan, action, achieving objective. Example for innovative teaching, multimedia, gamification, simulation, virtual reality. Innovation in clinical practice, cooperation, reflection in classroom, practice posing positive and concise question, learner response, develop listening and communication skills, develop self-confidence, prepare for shared governance. Why need to innovation? Global workforce, world using innovation and using technology in nursing and on all type of learning, it must be done. Growing demand in health service, improving quality of care, using nursing to produce information, protect health, prevent disease, personalized care. Health is required to have a well-trained nurse, deliver service management system to head innovation. Technology used in nursing education during the COVID-19. Educator in information age becoming a facilitator of learning rather than providing information. Integration of technology into nursing curricula is imperative to prepare student nurse for current practice environment. Technology in nursing education is used in both clinical and classroom teaching to complete learning. There is still gap in acceptance despite the upward trend, some of resistance from some people. Otherwise, in Saudi Arabia, 77.8% reported documented information in their smartphone, 24.5% always use them in clinical setting, 93.3% use their smartphone to access information, 89.6% WhatsApp study, 85.2 accessing social media platform for academic reason. This study done in Saudi Arabia 2020 by Said et al. How to using a smartphone for acquiring information and the communication. Social media in nursing education in Saudi Arabia, social network are fundamental tool in training for education of nursing. They offer new alternative for acquisition of theoretical and practical knowledge of nursing profession. YouTube was most used for social media for nursing education, about 46%, about 78% consider education content found social media platform useful for nursing education, about 87.5 facilitate learning for nurses. Jaxwa Classroom, team-based learning. Jaxwa as alternative learning strategy done outside traditional learning setup is effective strategy for teaching and understanding nursing students. Effective strategy for learning and developing other skills such as leadership ability, social engagement, study by Coriel et al. 2019. Challenges integrating technology in nursing, cost, lack of IT support, faculty, technology literacy, resistance to change, lack of faculty acceptance, rule of modeling, constraint to use in clinical setting. How to enhance technology in nursing education, enhance educator competency, improve technology competency, ensure readiness for future nurses for technology, enlarge environment by providing necessary knowledge in technology literacy, and give training about how to use technology, how to use the Blackboard. Saudi Arabia, يعني it's word of يعني كلمة في حقه في السعودي Arabia or words that good for Saudi Arabia institution and the government are well instituted to take full advantage of expansion of e-learning initiative. Nursing department need to explore use innovative teaching to improve development practice. Developing innovative teaching strategy must be driven from learner ability and need. This study shows a positive and negative effect of using technology in medical service. About 75% positive attitude about electronic record, negative about 19%, 47% remote patient monitoring, about 5% positive about artificial intelligence, 25% negative feedback. About telemedicine, 45% positive feedback and 12 negative feedback. Technology advancement and advantage on nursing, faster communication, increase efficiency, improve access to patient record, decrease burnout, reducing the staff shortage. Many nurses are excited by fresh set of eye on the problem. Disadvantage, threat to human element, generate divide, data security threat, implement challenge, sleep learning curve, steep learning curve, equipment malfunction, overlines on the machine. This is a question always spell and always asked by nursing student and medical student. Will the technology replace nurse in the future? Not. No technology replace the nursing in the future. It will not. The emotional component of caring cannot be spared. In busy hospital setting, nurses are required to make quick decisions. For example, if they are present with emergency and need to recognize their priorities, this need to be done quickly, speed, not needed to AI and reprogram. Nursing have constant complexity of the human brain, and not brain has pre-programmed to perform certain tasks. The emotional component of caring cannot be spread. Organization support smooth transition, perform nursing in nursing education, research on AI, graduate and undergraduate nursing education must develop competency development in health informatics, chief nursing informatics officer, digital health policy, investigate effectiveness on the patient research on AI and using of AI in nursing. Nowadays, I have a lot of the nursing research about AI, how to applying AI in nursing and midwifery room, how to using AI in technology and in teaching in classroom, explore the risk. Today, learners are different. Need to more innovative in teaching. Technology is powerful tool to enhance learning. Incorporation of new technology alone or combination with other methods reflect the direction of nursing education and nursing technology and nursing practice. Educators need to be creative in developing innovative in teaching. Creativity is thinking new thing. Innovative is doing new thing. Learning never end. Thank you very much.
Thank you very much, Dr. Amel, for your sharing. I think, yes, I really agree with your presentation. So we must move forward to use the technology in nursing education, right? Ready
No
or not?
option. No
Yes.
option. It's
No
mandatory.
option.
You know, learning new technology and how to learning Blackboard and how to using video conference. يعني advantage of Corona. You have to using conference online. How to using how to give lecture online. Before Corona, I didn't give lecture online or how to meet on Zoom or Team like now. Thank you for Corona.
Yes. I think Corona or COVID-19 is just an acceleration trigger. Even without Corona, we must facing the technology. We must do or we must face the reality that maybe in the next year, the next generation will live with technology. So we must maintain the technology. We must learning about the technology. I think the Corona just acceleration trigger or something like that.
Yes.
Okay, ladies and gentlemen, I will give you the opportunity to have a discussion. If you want to discussion directly, you can raise your hand, or if you want to write your question, maybe you can write in chat Zoom or privately in a committee. Actually, I have a question come from one of our participant, Miss Sunik. She's really shy, maybe. All right, again in chat Zoom. So she asked about the strengthen opportunity and challenges. What are the strength, opportunity, and challenges in implementing technology in developing country, such as Indonesia?
Yeah. First, cost, and need to train the IT and train the staff. But in my opinion, in Egypt and in Indonesia, in the same line, the cost need to be financial support, and all of us under estimation of financial support. In Saudi Arabia have good financial support, have very good, excellent IT program, and well trained in other side, and taking a PhD from America, from England, and حقيقي يعني it's real. Come a different person, how to use technology, how to use English language, how to use all the program. Cost, need to support. Financial support.
Yes, I really agree with you. Financial support, especially from our
Financial
government.
support.
Yes, especially from our government, right? So yes, I really agree with you. And we realize in Indonesia, the people the well-being for the people is not good enough, rather than the other countries. So we need the support from the government, especially from the coast, and because we can deliver, or we can inviting the teacher, we can buy some the technology, we can give the maybe awardee, we can do anything when the cost is enough, right? So yeah,
Enough. Not need more.
Yes,
L-
in Indonesia, our government now have a focusing about the food and security, maybe for the people, but actually after I think 1 or 2 months before now, our president announced that they can give the extra for education, but we don't know what is the portion for improving the education inside or maybe the outside. Sometimes the cost for the education they allocated for awardee, something like that, but they forget it about something like innovation in learning and give the support for the technology and something and exercise, something like that.
Yeah,
I really agree with you, Dr. Amel. Something like
yeah.
you
We don't need to, we don't need more discouragement. We only need to continuous support to keep us moving forward.
yes, really.
Okay? Yeah.
Yes, we must moving forward.
Yeah.
No standing or not. There is no change. There is no change. Not standing. Move forward. Okay, so something
Yes.
like your statement before, there is no choice. Yes, there is no choice to facing the technology, and there is no choice to continue the education. Just move forward. Okay, maybe all the participants, I give you an opportunity again if you want to ask or discussion. It's okay if you want to use bahasa. Ya, untuk teman-teman, mungkin saya buka kesempatannya. Silakan jika ada yang ingin didiskusikan, mungkin dengan bahasa juga tidak masalah. Ya, mungkin
The last word, surely the future will be better, made by our own effort. Okay?
Yes.
Yeah.
I really agree with you. I really agree with you, Dr. Amel. And Dr. Reda said, thank you, Dr. Amel. Yes, of course, I really happy to see Dr. Amel and Dr. Reda again. Okay, so many time we don't have a discussion. And now I have, and I can take a lot of the information, a lot of the insight for all of you. Okay,
We don't
teman-teman.
Yeah.
Yes. Oke, teman-teman, mungkin ada yang ingin ditanyakan, dipersilakan. Ada yang open kamera nih, Bu Niken mau sharing, Bu, atau mau apa namanya diskusi, boleh, Bu? Atau mungkin teman-teman nanti jika ada yang ingin tanyakan kembali atau ada yang ingin maybe the participant if you have some interesting research or maybe you want to ask later, you can contact the personal email from our speaker, or maybe you can search in maybe in Google or in a lot of the international high reputable journal. There are a lot of the research come from our international speaker. Okay, once again, thank you so much, Dr. Amel, for attending here. This is the certificate of appreciation, and we will send it by email to you. Still hope maybe one time.
Welcome. Congratulations for successful conference.
We can come or we can meet in person directly, as it's still my hope and still my doa.
Okay.
Okay, maybe we can take a picture together. Yes.
Yeah, have a nice day. Assalamu alaikum.
Yes.
I will complete my sleep. Okay, bye-bye.
Maybe we can take a picture together first before you continue your activity in this morning. It's still morning, right, in Egypt?
Yeah, still morning.
Is in Egypt or in Saudi right now?
I am in Saudi Arabia now, 9 o'clock.
Now in 9 o'clock, right?
Yeah, morning.
Oh, morning. Okay. I hope you can continue your activity today. Maybe we can take a picture together. I will count until 3. Maybe you can smile because I can see.
Saudi Arabia now, 9 o'clock.
Okay, 1. Mungkin yang bocor boleh di-stop. Okay, Dr. Amel. 1, 2, 3. Thank you so much, Dr. Amel.
Thank you. Bye-bye. Good luck.
nice day. Assalamualaikum.
وعليكم السلام. You too.
Okay, ladies and gentlemen, it's very full of insightful today. We have a lot of international speaker with a lot of information that can we learn more or that can we. Okay, no problem, Miss Niken Junior is okay for that. Okay, I will give you the information for tomorrow. Okay, don't forget, tomorrow we still have a schedule for the presentation. Oke, Bapak Ibu yang saya hormati, banyak sekali ya insight atau banyak sekali.
Please, Dr. Shaimaa, Dr. Shaimaa, Dr. Shaimaa, Dr. Shaimaa waiting you. Yeah.
Dr. Shaimaa is already here.
Dr. Shaimaa is present and
because
hello everybody.
Hello. Oh, Dr. Shaimaa, you already here? Professor.
Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Professor Shaimaa, you can hear my voice?
Yes.
Okay. Okay, ladies and gentlemen, before I give you the information, we have a connection to our last international speaker today, Dr. Professor Shalma Hasan Muhammadi. Good morning, Professor. Good morning.
Excuse me, can share PowerPoint?
Yes, you can try to share your PowerPoint maybe. Yes, our committee, maybe you can make Professor Salman as a co-host. Okay, now you are a co-host, Professor, so you can try.
You want me to help to share your PowerPoint?
Yes, or maybe the committee will help you, Professor.
Please, can share PowerPoint? Send by
Okay,
yesterday
the committee
PowerPoint.
will help you. Yes, mungkin dari kita Pak Dona boleh dibantu.
You can share PowerPoint of Dr. Shaimaa from your side.
Maybe the connection is noise for Dr. Prof. Charmini. Pak, bukan ini punyanya Bu Prof. Charmini.
This for Dr. Charmini.
Iya, ini punya Bu Charmini. Wait a minute.
Shaimaa Hasan.
Sharma.
Can you share because
Yes,
you
I sent it to Dr. Lavanya from today.
Wait, I will try to share screen. Maybe the connection better for me. Wait a minute.
Bukan itu ya, Bu Tuti?
Bukan. This is Professor Sharma. This is your PowerPoint?
Sorry.
Yes.
Yes. Okay.
This
Okay. Yes. Okay. Thank you so much, Professor Shaima, for coming here today. Now we can contact and we can have a good connection to you, ladies and gentlemen. Now we can learn again from our distinguished international speaker, Professor Shaima Hasan Muhammadi, Professor and Head of Maternal and Newborn Health Nursing Faculty of Nursing from Helwan University. To Professor Shaima, the time is yours.
Thank you. Hello, everybody. I will have to thanks for chance to presentation about midwifery lead care, a comprehensive approach to maternity care. To complete this is presentation, definition of midwifery lead care, incidence rate of midwifery lead care, benefits of midwifery lead care, models of midwifery lead care, core principle of midwifery lead care, barriers to midwifery lead care, the role of midwife lead care, definition of midwifery introduction. Midwifery care is evidence-based model that emphasizes continuity of care, woman-centered, holistic support and empowerment of women throughout pregnancy, childbirth, and postpartum period. Internationally recognized for improving maternal maternal and neonatal outcomes. The World Health Organization and the International Confederation of Midwives recommended as a childbearing individual first care choice. Worldwide evidence show that the model positively influence long and short-term health and well-being of childbearing women and their infants. It is a positive effect on maternal satisfaction and show cost-saving trend. Internationally recommended international recommended as a quality of care measures. Definition of midwifery lead care is a model of care in maternity service in midwifery lead care that midwife is a lead professional in planning, organizing, and providing care to women from antenatal booking to postpartum period within multidisciplinary network of consultation and referral with other health providers. Incidence rate, pregnant women should have access to high quality maternal care or competence maternity care, which is a fundamental human right. However, every day nearly 23 women die worldwide from causes related pregnancy, childbirth, postpartum, or gynecological problems. The majority of this occur in low and middle income countries. Accountability 95% of maternal deaths and 90% of all children deaths worldwide. The effect of midwifery lead care reported that midwifery lead care should avert about 2/3 of this among women and decrease neonatal deaths by 60% and preterm birth 24%, reduce obstetric intervention by 30% and decrease the number of severe adverse maternal outcome and postpartum incidence. Incidence rate of benefits of midwifery lead care are legally allowed and competent practice independently and autonomy to provide antenatal, intra, and postpartum care in hospital and primary care setting to women with an uncomplicated pregnancy, labor, and birth, include home births. In primary care, midwives work independently in group practice or public health organization. Of the practicing midwife, 28% work in hospital setting, 9% of in primary care, 30% compound both, so the midwives lead care. Act on maternal outcomes. Maternal outcomes and fetal outcome. Maternal outcomes, low intervention rate, cesarean section, instrumental delivery, higher maternal satisfaction, less need for epidural analgesia, better emotional and psychological support. Fetal outcome, improve bonding and early skin-to-skin contact, reduce preterm birth rate, higher breastfeeding initiation. And we need to decrease the rates of cesarean section and increase the rate of vaginal delivery. Midwifery model care can increase and awareness to the mother and the nurses for vaginal delivery. Model of midwifery lead care. All health care is based on value and attitude that are sometimes illicitly expressed in theoretical framework or condensed as a model for care. A modeling study led by Universal Federation and ICM and WHO in 88 low and middle income country. MICS estimated that an universal reach to midwifery lead care would prevent 67% of maternal deaths, 64% of neonate, 65% of stillbirths, and save 4.3 million lives per year by 2035. Models, one models of midwives lead continuity of care. The first midwife model. The most provide continuous care by the same midwife, a small team, or midwives throughout pregnancy, labor, and postpartum period. Continuity of care, continuity of information, continuity of philosophy, and woman-centered care. Benefits reduce the intervention rate, low cesarean section, and high care of maternal satisfaction. Lower cesarean section rate. Second model, the midwife lead unit model. This model, next. This model is designed for women with low risk pregnancy and are retained by midwives. Alongside midwife lead unit located with or next to hospital or obstetric service can be inside the obstetric service or hospital beside the obstetric clinic. Comfortable environment with rapid access and medical care. Freestanding midwifery lead unit is separated from hospital. Can be out the hospital. High rates of natural birth and minimum intervention. Next, three models. Caseload midwifery models. A primary midwife takes responsibility for define a group of women, characteristic personal care, home visit, availability. Every three women can one midwife. 24 every 7 midwives. Benefits highest continuity, excellence maternal satisfaction. 4 model. Team midwifery model, a team with midwifery women, 6 to 10 midwives that share responsibility for a group of women, balanced workload among midwives, moderate continuity of care. 5 model community midwifery model. Midwives work then with the community, providing antenatal, postnatal, and educational support. And benefits increase the accessibility, a strong culture, and psychosocial support. 6 home birth midwife model. Midwives provide full care for planned home birth for low risk pregnancy, not high risk pregnancy, low risk pregnancy. Benefits familiar environment, lower intervention rate. 7 models. Share care model. Midwives and physicians collaborate with midwives providing routine care and doctor managing complication. Benefits useful in area without midwifery lead unit. Suitable for low moderate risk cases. Core principle of midwifery lead care models operate on interconnected principle and work together, create comprehensive care framework. This principle emphasizes the importance of treating women as an individual. We recognize the natural process of childbirth. The following principle from the foundation of the effective midwifery care delivery. Barriers to midwifery lead care. These slides show the principle for women-centered care, continuum of care, holistic approach, empowering through information, promotion of natural birth, community integration, collaboration, and referral, respect for autonomy, focus on health promotion, evidence-based practice, implementation, midwife-led care, collaboration, practice, training, and education, resource allocation. Barriers to barriers to midwifery late care. 7 barriers: health system barriers, the lack of support policies, limiting midwives' autonomy, mediated maternal system, weak referral, and the limitation government funding to midwifery late unit. Professional barrier: shortage of training and experienced midwives, resistance from obstetricians and hospital, low professional autonomy, and restricted scope of practice, poor interprofessional collaboration. Education barriers: inadequate inadequate midwifery education, focus on medicalized births, limited opportunity for continuing professional development, insufficient training of community-based and normal birth models. 4 barriers: culture and social barriers, public misconception the doctor are safer than midwives, culture preference for obstetric lead care, gender and poor dynamic undervaluing midwifery. Barriers 5. Next, operational and infrastructure barriers. Few midwifery lead unit or birth centers, high workload and burnout among midwives, poor working condition and lack of resources. Legal and regulatory barriers: restrictive law limiting independent midwifery practice, fear of litigation lead to the over mucilage care. Patient-related barrier: lack of awareness about midwifery care option, fear of complication leading conference for hospital, low health literacy making comparison difficult. Role of the midwifery lead care: be professionally curious, taking steps to understand the reason why women are making their individual choice, and promote positive relationship with them during all contact and conversation. Able to describe the role of the midwife in supporting women, enhancing safety and reducing risk during their maternity journey. Keep women at the center of their decision making. Respect the woman's decision or to engage with any all part of the midwifery care offers. Be informed by and work within the relevant law of the country in which are practical, evidence-based, and up-to-date policies and procedure. Next, provide care that respectful, fair, free from discrimination, and without bias. Include any bias against protected characteristic. Recognize that some women may be fearful about giving birth, particularly in an NHS setting, nursing hospital setting. Use as a culture competent approach to understand reason why women choose or to free birth or birth outside the guide. Promote evidence-based discussion without women, including information and respect to pathway and support that can over to relieve risk about should they be present or develop throughout the pregnancy and the childbirth experience. Respect and work in partnership with the woman in a suitable manner to express optional and the full range of available choice to environment of her midwifery care. Explain the risk and the benefits of in care choice. Next, respect and work in partnership with the woman and explain the risk. Provide care that is based on the informed consent of the woman. Informed consent is is important for any procedure or any choice for women, especially written consent, not oral or verbal consent. Any procedure can be practiced where the woman can be informed consent. In phases, women opting out midwives the care that can resume the care whenever they choose, without judgment, or such as cases ensure that the woman known how and who to contact. About the procedure and the dynamic, the independence phase have clear chance to access appropriate future information, advice, and support that needs a scenario to better information quality of woman center with the woman. Work and train with the multidisciplinary team to promote best outcome for the woman and the newborn, such as obstetrical, such as the counselor, such as family clinic, such as the referral to different hospital of maternity and newborn. Work with their maternity team using all their knowledge and skills to ensure the physical, psychological, social, cultural, and spiritual safety of women and adapted the care to meet their needs. Investing in midwives is a cost-effective way and improving health outcome. Thank you. France, thank you for attention, and thank you for give me a chance to present the presentation. Nice day.
Okay, thank you so much, Professor, for your sharing. It's a very structured material. It's very structured from the problem, barriers, and how we can overcome this problem. This is very full of insight that I can learn from you. Okay, ladies and gentlemen, if you want to directly to discuss with Professor Shalma, how can I spelling your name, Professor? I am really sorry. Shalma or Prof. Hassan? Maybe Prof. Shalma, is it okay?
Shaymeh.
Shaymeh. Okay, Prof. Shaymeh, thank you. Okay, one question, Professor, come from our participant, Ms. Sunik, asking about the model of midwifery lead care. There are a lot of model in midwifery lead care. We must use all model, or we can choose the best model based on our resources and problem.
All models can be implemented in little cost, because midwives need training, need education. The education and the training by program curriculum, and the models can be implemented as a system in the health ministry during the school of nursing, during education program in faculty. Practice can be implemented practice program about the models, and can be implemented in community, because faculty of nursing, faculty of forensic can be implement this program in the about special program in faculty. And the program in Egypt found the program related Ministry of Health, and the Faculty of Nursing can be implemented about midwifery training and practice knowledge, and IA in implementation of give mothers give more knowledge and practice, many thesis and many project implemented to give mothers about information pregnancy, labor, postpartum care, management of postpartum hemorrhage, postpartum management, referral to any hospital can be help the mother. Resources of implement this models maybe found in little cost.
Okay, all of the model is acceptable in low resources and low cost, something like that, Professor, right? So we can choose or we can apply all of the model. I think yes, I really agree with you. All of the model, I think we can apply in developing country, even though we have a limited of resources. Not optimal, but it's still can feasible to apply something like that. Okay. Prof. Saima, maybe actually we have one question, but you already answer the next question about LED midwifery lead care in Helwa, but you already answer about this. So I think the participant who are asking about the midwifery lead care program exists in Helwa University is already, and you can read or we can hear again about the answer. Okay, maybe committee you can prepare the certificate for Professor Shewa. Excuse me, Professor, can you spelling again? Shema. Oh, Shaime with E, because yes, in Indonesia we especially for me, the Arabic pronunciation that I common use is A. No A, A alpha, not A elephant, Shaime. But if you write your name with Shaima, I will pronounce Shaima. So maybe the correct pronunciation is Shaime. Something like this. Okay, Prof. Thank you for your attending our conference. We hope we can invite you again, Professor, in the next conference. And I think maybe a lot of information that we can share again, that we can explore again about the maternal and newborn or about nursing education. Okay, this is a certificate of appreciation for Professor Shaimi Hassan Mohammadi, and we will give you by email. Thank you, Prof. Shaimi.
Thank you very much. Nice day.
Nice day for you too, because it's still early morning in your country. Again, ladies and gentlemen, thank you so much for joining with us since in the morning until now. And I will give you the announce for tomorrow. Yes, tomorrow we still have an agenda, very important, about the presentation and oral for oral participant. This is the term and requirement for tomorrow about the participant, active participant, I mean. We hope all the active participant will prepare your best performance, yes, because the committee is preparing 2 or maybe 2 until 3 special certificate for best presenters. So I hope you can give us your best performance. Okay, I will inform you for the term and the condition or presentation tomorrow are follow. First, please replace the Zoom name with your format, something like your name underscores oral. Because in the second day, not only an active participant will join, the passive participant will join it too. So it's make me easy to see your name in Zoom. Or if you come to your account, please use your full name based on your registration, right? Yeah. Jadi saya akan memberitahu syarat dan ketentuan ya untuk memudahkan kelancaran oral presentasi besok. Yang pertama adalah diharapkan menggunakan nama dengan format nama underscore oral presenter atau menggunakan nama asli sesuai dengan yang didaftarkan pada panitia. Karena tidak hanya peserta aktif yang akan bergabung besok, ada peserta pasif ya. Jadi kalau nama teman-teman nanti berbeda atau mungkin nama panggilan yang dimasukkan, nah itu akan menyulitkan saya untuk mencari teman-teman. Tapi kalau nama teman-teman dengan nama asli, saya akan lebih mudah untuk mendeteksi keberadaan rekan-rekan. Because we just have one room for oral presentation, so make sure you use your full name or you can make your account in Zoom into your full name based on your registration. Okay, the second, all the participants, please join the Zoom meeting 15 minutes before the schedule of the first presenter, because the presentation time can be faster based on the speed or based on the time from the previous presenter. Ya, jadi saya memohon teman-teman bisa bergabung paling tidak 15 menit sebelum pemateri yang pertama terjadwal ya, karena kan kecepatannya akan bergantung pada kecepatan pemateri yang sebelumnya atau presenter sebelumnya. Jadi bisa saja oral presentasi ini akan berlangsung lebih cepat atau mungkin lebih lama ya, tapi biasanya kalau tidak ada pertanyaan kan akan kita next. Jadi biasanya kecepatannya itu akan berbeda-beda. Biasanya lebih cepat, tapi tolong masuk 15 menit sebelum presenter pertama ya, bukan sebelum waktunya teman-teman gitu, takutnya akan terlewat seperti itu. Because if the presenter called your name 3 times but I cannot find you in Zoom or you cannot answer my call, I will continue to the next presenter. All right? And then I will call you again after maybe the last presenter or a minimum 2 presenter has been presented. Oke? Nah, karena kalau terlambat ya saya panggil 3 kali namanya tidak nyaut begitu atau tidak menjawab panggilan dan saya tidak menemukan nama teman-teman di ruangan Zoom, saya akan melanjutkan kepada presenter berikutnya. Ya, dan nanti akan dipanggil lagi di akhir atau minimum kalau sudah datang saya harus memaju 2 dulu ya, memajukan sesuai dengan jadwal paling tidak 2 orang. Jadi akan tertinggal minimal 3 orang seperti itu. Okay. And then the allocation time is very important for question and answer tomorrow is 10 minutes, including the discussion. And the maximum time for your presentation, I hope you can spend 6 minutes. Alright? Oke, waktu untuk presentasinya besok sekitar 10 menit, yaitu sudah waktu total, ya total dengan diskusi. Jadi saya harap teman-teman bisa selesai di 6 menit ya untuk presentasi. 4 menit kita spending untuk diskusi seperti itu. Okay, I think it's more important if more than one author will join in the Zoom room is still to represent. They are still welcome to join. But the certificate still we will given to the name who has been registered before. Okay, or if you want an extra certificate, you must call the committee. Ya, jadi kalau dalam satu tim, ya satu tim riset nggak mungkin sendirian ya, lebih banyaknya biasanya banyak bareng-bareng, sendirian sih mungkin, tapi kecil kemungkinan sendirian, biasanya banyak bareng-bareng, atau mungkin ada dosen yang ingin melihat seperti itu dipersilahkan ya, dipersilahkan masuk ke ruangan Zoom untuk melihat jalannya presentasi. Tapi nanti sertifikat tetap akan kami berikan kepada nama yang terdaftar. Dan jika ingin menambahkan sertifikat diharapkan untuk menghubungi komite atau panitia seperti itu ya. Mungkin ada beberapa yang syarat kelulusan gitu harus dilihat oleh oleh dosennya, itu dipersilahkan, atau kalau mau rekaman juga dipersilahkan. Oke. And then if you want to replace or if you want to presentation on behalf of your teams during this situation or this unconditional situation is still welcome. You can contact me and I will ask your name to represent the previous presenter. Or if you want to on behalf or you want to present in addition your team or your friend who has been registered cannot come, you can contact me or you can answer my call when I call the presenter name. Ya, jadi kalau mau menggantikan ya atau mau mewakili teman yang memang sudah terregistrasi tapi karena satu dan lain hal tidak dapat hadir tapi masih satu tim peneliti, itu dipersilahkan. Boleh menghubungi saya, nanti saya akan panggil namanya yang mewakili, atau jika memang tidak sempat, jawab saja panggilan nanti ketika saya menyebutkan nama presenter yang terdaftar. Semisal saya dengan Bu Livana, nah saya tidak bisa hadir, Bu Livana hadir ketika saya menyebut nama saya ya, atau ketika saya menyebut nama Bu Livana, saya akan menjawab untuk mewakili. Tapi nama yang harus berada dalam satu tim penelitian seperti itu ya. Okay, and for the deliver language, this is very important, and all of the participants always ask me about the deliver language. Can we use Indonesia or must have in English? We prefer all of the participants to practice in English, yes, especially in presentation. Okay, we give you the template for the PowerPoint presentation. You can read your presentation in English. We hope so. It is just for our exercise. And if you want to ask the question, if the question coming from the participant or from our blended reviewer, if you want to use bahasa, is still low. Or if you want to discuss, if you want to ask to the presenter with bahasa, it's still low, all right? But for the present, and for your performance, for your deliver the material, please use English. Ya, ini penting. Biasa suka nanya untuk bahasanya mau bahasa apa begitu ya. Nah, dipersilakan jika teman-teman ingin menggunakan bahasa Indonesia tapi dalam sesi diskusi ya. Kami berharap untuk berlatih bersama kita untuk tentunya mau tidak mau ya, straightforward. Sesuai dengan template yang sudah dikirimkan oleh panitia kepada teman-teman untuk presentasinya menggunakan bahasa Inggris. Adapun nanti jika ada diskusi, ada pertanyaan dari teman-teman ataupun dari blended reviewer, dipersilahkan menggunakan bahasa Indonesia. Oke, jadi teman-teman yang mau bertanya pun dipersilahkan menggunakan bahasa Indonesia ya, jangan hanya karena harus berbahasa Inggris, tadinya mau nanya nggak jadi nanya, nggak apa-apa. Kita mementingkan seadanya diskusi yang berjalan dalam presentasi nanti. Okay, but for make sure the quality of the conference, because this is recorded, of course, I will try my best to give the short communication or the conclusion in English. Ya, tentunya untuk menjaga kualitas dari konferensinya yang nantinya mungkin akan terekam. Nah, setelah ada diskusi dalam bahasa Indonesia, saya akan berusaha semaksimal mungkin memberikan kesimpulan yang nanti disampaikan dalam bahasa Inggris. Seperti itu. Okay, this is our information, very important information for all of you. We have a blended reviewer. The reviewer can give the question based on their name, or actually they can give the question come from me. So I will give the question to the participant. But if the passive participant or the committee who join with the discussion, they can ask, of course. But the first opportunity I will give to the participant and then the blended reviewer. Oke, nanti akan ada penilai yang tentunya tidak diberitahu namanya, biasanya akan menitipkan pertanyaannya melalui saya. Dan nanti ada peserta pasif juga dan juga panitia tentunya yang tergabung dalam ruangan Zoom dan mereka semua dipersilahkan juga untuk bertanya dan berdiskusi seperti itu. Okay, ladies and gentlemen, this is all of the requirement for tomorrow. If you have some question, do not hesitate to ask committee. Maybe you can contact us in WhatsApp group or maybe tomorrow you can ask me directly. Oke, jadi itu tadi adalah informasi-informasi penting yang akan kami sampaikan, dan jika ada pertanyaan yang akan diajukan jangan ragu dan juga jangan malu untuk bertanya, bisa melalui kontak WhatsApp dengan panitia atau esok pagi langsung dengan saya. Okay, as a master of ceremony today and also a moderator, on behalf all of the committee, we will say thank you and really sorry and we also give you the best, try to give you the best, but maybe some condition make you uncomfortable, we will really sorry for an inconvenience. Oke, tentunya saya mewakili panitia dan juga teman-teman berusaha untuk memberikan yang terbaik, tapi jika ada yang kurang berkenan atau ada yang kurang pas, kami memohon maaf. Oke, our honorable participant, see you tomorrow, and for all our distinguished international speaker and national speaker, thank you so much for joining and for delivering the material. We will see you maybe in the next conference. And for all the participants, we will see you tomorrow on Zoom. So, wassalamualaikum warahmatullahi wabarakatuh. Good afternoon in Indonesian time. And see you tomorrow in 8 o'clock in Zoom for oral presentation.